colleges are doing fine. All the medical colleges are doing fine, and I'm sure that all the PGs are benefited with this program. Thanks to Dr. Anderson sir and Dr. Mohandas and our South Zone coordinator, Dr. Thomas Verghese, and all the HODs for making this program a grand success. And going to my job, first of all, let me welcome our faculty today, Dr. Shahnaz Ahmad, our brother of our legendary Sulfika sir, my teacher.
Thank you, sir.
And welcome,
Thank you,
Dr. Welcome, Dr. Shahnaz.
That I didn't know. Thank you.
And I also welcome our state coordinator, Dr. Mohandas, for this meeting. I welcome all the our HOD, Darli Madam, who is present there in all meetings. I welcome our senior faculty, Dr. Srinivasan sir and Shusha Madam, who has been present in all the meetings along with the PGs, even though many other senior faculty are not there. Both of them will be there. Along with Purushottam sir, I am sure he will be joining soon. And I also welcome our past state president, Jayaraman sir, for this meeting. And all the faculties, Dr. Bindu, Dr. Kirti, Dr. Bini, and all the friends of IAP Kottayam and all the postgraduates for this program. Thank you. Jai Hind, Jai Hind.
Jai Hind.
Okay. Next, addressed by Dr. Mohandas sir, State Coordinator, PG Club.
Good evening, all. It is my proud privilege to be part of this program. And this week, Kottayam IAP is organizing this event. I would like to congratulate officials of Kottayam IAP, Dr. Bala, Dr. Sumita, and Dr. Sahela, and also this coordinator, South Zone coordinator, or the coordinator for this program, Dr. Thomas. And this week, the discussant is Dr. Shahnaz Ahmad, already introduced, is the pediatric neurologist of SAT Hospital, Thiruvananthapuram. And mentor is my dear friend, Dr. Cyril Rosario. And the presenter is Dr. Arathi Aravind. I would like to congratulate all for taking effort to be part of this program. Welcoming all senior faculty, Sushma Madam, Srinivasan sir, Jayaraman sir, Darli Madam, all in this program. Thank you.
Next, I invite Darli Madam to say a few words.
Am I audible? Yes.
Yes, ma'am.
Yes, madam.
Yes. The computer in the Mari carry the audible. Good evening, everyone. I'm happy that to be a part of this particular online program. And I wish all success for the program and also to my student Arathi and for the mentor, Dr. Cyril also. Thank you. Thank you very much.
Next, I invite Cyril sir to introduce the speaker, the case, and the presenter.
Good evening, everyone. Respected teachers, and PGs. Today, we are presenting a 10-year-old boy with history of frequent fall and difficulty in climbing stairs. We are happy to have Dr. Shahnaz Ahmad as our speaker. He is the associate professor.
Thank you, sir.
Welcome. Associate professor at SAT Hospital in the Department of Pediatric Neurology. The case will be presented by Dr. Arathi. She is a third-year JR in our institution, that is ICH Kottayam. Thank you.
Thanks.
Next, we can start the discussion, sir.
Okay.
Arathi, you can start screen sharing.
Okay. Is screen sharing visible, sir?
Yes, yes.
Yes.
Thank you, sir. Good evening to the respected IAP members, my teachers and colleagues. Today I'll be presenting the case of a 10-year, 2-month-old boy hailing from Kottayam. He was admitted on 13th this month of 2024 and examination was done on 15/8/2024. The informant was his grandmother, with whom he is now residing, and the information is appeared to be reliable. The presenting complaints, frequent fall for past 1 year, and excuse me. Excuse me, sir.
Difficulty in climbing upstairs.
Sir. Difficulty in climbing upstairs for past 6 months and difficulty in getting up from squatting position for past 6 months. And the history of present illness, the 10-year-old boy was apparently normal until a year ago.
Aradi, can you, shall I interrupt in between?
Yes, sir.
That is, the first complaints began with the first symptom was recurrent falls.
Yes, sir.
So you said like Venkateswaran and two or names were said by Thomas. Who are they? Venkateswaran.
Yes, sir. Yes, sir.
Then
Venkatesh is
Divya
here,
Gobinath.
Divya
Divya
Gobinath.
Gobinath.
Three PGs. Three postgraduates.
Yes,
Okay.
yeah.
I begin with Venkateswaran because one of my favorite hotel is Venkateswaran. So Venkateswaran, one question for you. What are the modes of diagnosis in pediatric neurology? Modes of diagnosis. MODES.
Like based on the clinical symptoms, signs and symptoms.
When you look at the presenting complaints of Aradi, presenting complaints only, not the history of presenting illness, what do you notice? She has written 3 things. That is, first, there is a fall, then difficulty climbing stairs, and then further other difficulty. So when you look at that pattern, what you got something, isn't it? Let us look at the presenting complaints. Frequent falls, 1 year. So after 4 months, he has difficulty in climbing upstairs. Then he gets further difficulty in the form of getting up from squatting position. So they're in a chronological order. When you look at that, these 3 complaints, what is the what is the mode when you look at totally at these 3 complaints? You make a diagnosis quickly. You can make a diagnosis. What is it? What could be the possibility when you look that you can say that it is a muscle, most probably, because we have that is called pattern recognition. You are recognizing a pattern. For example, if I tell you headache preceded by flashing lights and followed by vomiting, what is the diagnosis that you make? Headache preceded by flashing lights, followed by vomiting. What is a very common diagnosis that you? Migraine. Yes. Okay. So your audio is not very audible. Gaurav has typed something. Okay, that migraine. Okay. So are you able to hear me, Venkat?
Yes, sir. Yes, sir.
Okay. Okay. So that is migraine. Like that, when you quickly look at this frequent falls 1 year, difficulty in climbing upstairs, then difficulty in getting up. So you notice that there are 2 things you can. There are 2 things you can make. Initially, weakness is there. Then the weakness could be proximal. So that impression you can make. Then also, when you quickly look, you can also make a quick diagnosis of a muscular dystrophy or a muscle. Especially even from the presenting complaints, we can make a localization based on the symptoms. Okay, that is so. Any other mode of diagnosis in the pediatric neurology other than this pattern recognition? Very in neurology. So let me ask neurology. In neurology and pediatric neurology, there is another pattern also. Can you tell? I will give you some time, no problem. Anybody? Gobinath. Gobinath, can you hear me? Okay, then one more person was there. Gobinath, Venkateswaran, and Divya. Okay. Divya? Are you able to hear me, Divya?
I think Dr. Gobinath and Divya is not there in the.
Oh, no problem. No problem. Then, okay, no problem. Then the another mode of diagnosis is called localization. Localization is in adult neurology. Localization is the most important technique for diagnosis. Even though pattern recognition also we use. Any other mode of diagnosis other than these two in neurology? In fact, in medicine also, especially in neurology. Arathi?
Symptom-based diagnosis, sir.
No. The symptom analysis is part of the localization and other things. But symptom analysis is the method through which we make the diagnosis. Another technique of diagnosis, physical diagnosis. And so you see someone walking in a stooped posture, very slow, very slow manner, stooped posture. What is it? That is Parkinsonism in a slow manner. So that is physical. So there are three techniques of diagnosis. And other, like Gaurav said, the other things in finer things in pediatrics, like pedigree-based diagnosis, also you can make if you know how to draw a family tree correctly. That is applicable in genetic conditions, maybe. And X-linked recessive, autosomal recessive, etc. So this, and let me ask my second poor Venkat. Only Venkat is there to answer the questions. But Gaurav, I think, is a senior PG. Gaurav is a senior PG? Yes, sir. Can I ask Gaurav? No problem. So, Gaurav, how do you know the first complaint? Let us take the first complaint. Frequent falls for the past 1 year. So, how do you analyze falls, Gaurav? Whatever idea you have, you say. Don't hesitate. Because I usually used to make a lot of mistakes in my MBBS. Whenever the teachers ask something, I answer, and most of the answers are wrong. But with the firmness I am saying, they will think that it is right. So, Gaurav, no problem.
Yes, sir.
You
Sir,
tell.
I am audible, sir.
You are audible. You are audible.
So frequent falls, sir, can be localized to various other things, sir. First of all, we have to rule out if the child is in a toddler or infancy age group. We have to rule out the vaccination first. Second thing, sir. Second thing, then we have to look if any systemic systems are persisting or not, sir. First of all, the fever is present or not. So then we can localize to any systemic disorders related to arthritis and everything, sir. Then comes the, sir, if we are localizing to the CNS part, sir, we have to see whether there is a lesion of the element type of lesion, sir. If starting from the anterior oncels to the muscles, sir. If in such case, sir, we have to localize based on the in the element part where we have to localize it, sir. So now, if frequent falls can be, sir, due to proximal muscle weakness, which is most commonly seen, sir. So,
okay. Then Gaurav, can I interrupt?
Yes.
Your approach is very good. Yeah, actually, you approach it better than me in the way that you first thought about other things like illnesses and all that. But like fever or other systemic illnesses causing difficulty, weakness, etc. That is very good. That is very good approach. That is especially applicable when you see a patient coming with difficulty in walking in the casualty. The first thing that you look for are mechanical difficulties like pain and other mechanical difficulties. Then only you go to the neurology. That is applicable in a child who is coming with a limbing or walking difficulty. But in the case of falls, actually we are, nowhere in the presenting complaints we are complaining regarding a febrile illness or anything. When you analyze fall for a long time, let's say comparatively 6 months or 3 months, recurrent falls, that actually we mostly take it as a neurological thing only. When you analyze the neurological thing, you don't go directly into the LMN or UMN. You first analyze the symptom like this way. Falls with the loss of consciousness, falls without loss of consciousness. That is the first division. Okay, Gaurav. That is the first division. Falls with the loss of consciousness and falls without loss of consciousness. Second division, you take the falls with the loss of consciousness. What are the possibilities? One is syncope. Second is migraine. Third is seizure. Okay, then there is migraine. How migraine with there is an entity called the migraine with the syncope. So there can be headache followed by fall. So you are these are the three major causes. Then other causes are also there. For example, arrhythmias. Arrhythmias are there. Arrhythmias can cause recurrent falls with loss of consciousness. Then you can have TAS, especially in older people. Now, then the second thing, that is falls without loss of consciousness. That is to be further subdivided into falls with vertigo and falls without vertigo. This is how we analyze. This is called symptom analysis in neurology. But the thing is, Gaurav and Venkit, the thing is, in pediatric neurology, when we take the conditions in general, the most common condition is febrile seizure. Then comes the four things, that is the developmental delay, epilepsy, then cerebral palsy, mental retardation, language disorders, etc., etc. So when you take the first four main complaints in pediatric neurology, the localization is actually already there in the name itself. That is why pediatric neurology is slightly different from adult neurology. In adult neurology, localization is the main thing. But in pediatric neurology, we can have a lot of pattern recognition, as well as the thing is that there are three axes in neurological diagnosis. That is the functional diagnosis, localization or anatomical diagnosis, and the etiological diagnosis. When you analyze when I told you, Gaurav, to analyze a fall, you immediately jumped into the etiological diagnosis, like infection, etc. You should never jump like that. Always you take the symptom and try to find out what is the functional deficit. Then you try to localize it, then you jump to the etiology. After localizing it only, otherwise we will become wrong. But we are very fortunate, pediatric neurologists and pediatricians are very fortunate that that much complex localization is not required in our cases, because our cases are more obvious cases, because most of the diagnoses are constituted by the first four things: cerebral palsy, developmental delay, epilepsy, febrile seizure, and all. And then comes the other easy to diagnose pattern recognition conditions like meningitis, demyelinating disorders like ADEM, then migraine and other conditions. Then comes the other group, the genetic dysmorphic syndromes with the brain abnormalities and neuronal migration disorders. All these have various presenting features. But when you analyze this case is similar to an adult case in the sense that there's a gradual progression, frequent falls. So let us come back to the falls without loss of consciousness. There can be divided into falls with the vertigo and falls without vertigo. So falls with vertigo, Venkit, Divya is not there. That's why, Venkit, can you tell 2 or 3 common causes of falls with vertigo in children, not in adults?
So acute migraine, some percentages.
Falls with vertigo. When you yes, there is a migraine variant. Can you tell the name of that? There's a migraine variant, usually occurring in children between the ages of 2 to 4, where there is a tendency for fall with the vertigo. Sudden vertigo comes. What is that migraine variant called? Gaurav?
The breath holding spell, sir?
No. Something similar to, but begins with the B only. B. Two to 4 years, usually. I will tell you the symptom. The child suddenly becomes afraid looking, a little pale, and comes running and catches hold on to the mother's leg to avoid falling. What is that condition? It occurs in children less than 4 years. Yes. One letter is, Rajesh, you are right, but one letter is not there. BPV, benign paroxysmal vertigo. Rajesh typed correctly, BPPV. BPPV is benign paroxysmal positional vertigo. That occurs in older adults, 30 to 50-year-old people with vertigo due to vestibular involvement. But here it is BPV, benign paroxysmal vertigo. So any other condition in children with vertigo and fall? You can have this, vestibular neuronitis due to viral infection. Labyrinthitis can be there. Ear complaints usually coming in ENT, CSOM or aggravation of CSOM. All these complaints can cause vertigo. but we don't see that much case of vertigo usually here. So any other localization for vertigo other than vestibular apparatus? Can you tell two more localizations for vertigo? I will ask Rajesh. Rajesh, you tell two more localizations for vertigo other than vestibular apparatus in children. Or Gaurav, you can contribute.
Not sure, sir.
That is, you can have basilar migraine. You know, basilar migraine. Basilar migraine is, you get diplopia, dysarthria, ataxia along with the migraine attack. Okay. Then another possibility, you can always say TA, but TA is very common in adults only, not in children. Then you can have tumors of the posterior fossa, which can cause has intermittent pressure increase and vertigo. And also example like arachnoid cyst can also cause intermittent vertigo. Then another condition is cavernoma. Cavernoma can come in the brainstem or cerebellum with vertigo, intermittent vertigo. Sudden small bleed can lead to sudden increase in the symptoms. Okay. Now comes the most important part. This is a simpler things only. Now let us take the fall without vertigo. In that, Aradi, because we are Aradi presenting, she may have read about it. That is why I'm asking her. Because other PGs are unavailable. So the thing is, Aradi, can you tell falls without loss of consciousness and without vertigo? That is the case that we are discussing. How do you go about that? Such a case?
So it could be due to some proximal muscle weakness, muscle pathology.
No. Don't directly go into that. That is a mistake that we tend to make. Whenever we hear a case with the proximal weakness and tendency to fall and difficulty rising, we have a tendency to directly go by the pattern recognition into the commonest thing that we know, that is muscular dystrophy. But that is not the way. That is because proximal weakness could be due to other localizations also. See, anterior horn cell. Okay, anterior juvenile SMA, anterior horn cell can be there. It can be neuromuscular junction, myasthenia. It can be endocrine myopathy. It can be metabolic myopathy, mitochondrial myopathy. So many possibilities are there. So it's not dystrophy alone. It could be due to nerve problem, like nerve root affection problem, coda echina affection. So, okay, without vertigo, how do you approach it? I will give you 1 minute. Meanwhile, Venkit and Venkit, Gaurav, etc. also can also think and contribute. Manu can contribute because I don't know all of you. That is why I'm saying some names only. Anybody can contribute. Don't be afraid. Even if I am refuting you, this is a good attempt. We Indians must be like that. We must react.
So due to visual problems.
Okay, that is a very good, that's a very good one. Very good one. Okay, very good. Visual problems. Very good. Because visual problem. Can I ask you one more question? You are not disturbed by, if you are not disturbed by my questions, I told you that I will not ask you anything, but Divya and other people are not there. That is why I'm asking you. Okay. Then the visual problem, among the visual problem, how can you dissect two things? Two localizations in the visual problem itself. Any other localization?
So
visual problem is a very good answer. Very good answer. Even I also did not note it down. So that is why I'm saying it's a good thing. Visual problem. We usually don't speak about it, but it's a good suggestion. Visual problem meaning decrease in visual acuity. That is correct. That is correct only. Then another possibility. Any other possibility?
And also due to diplopia, sir.
Very good. Diplopia. Correct. Diplopia. I have a patient with the diplopia, especially when looking downwards, will find it very difficult to walk. Because he may tend to fall down because of the apparent image also. So now, any other functional. So you understand now the technique. Technique is not to go into the localization directly, but first to take the functional deficit which causes the fall. Then after finding out what functional deficit is causing the fall, you try to localize. Okay. So now what about the second thing other than visual problem? The most common thing, weakness.
Any food deformities.
Okay.
Like
deformity. That actually okay. That like club foot or other deformities.
Flat feet or pigeon
flat
point.
feet. I will tell you regarding one case which actually came with the recurrent falls and all that, and many people had branded it after seeing so many doctors. So many people had branded it as a dystrophy or a very dangerous problem, etc. But when I analyzed that child in my OP, I found out that he had ADHD, attention deficit hyperactive disorder. But see, ADHD per se also can cause recurrent falls. But that patient had one more condition, which is not a neurological condition. In the mechanical, the mechanical aspects of the limbs. Can you tell what it is? Can you guess what it is? ADHD with one problem can cause recurrent falls, as though mimicking a neurological disorder. One more problem in the mechanical aspect, nor in the neurological. In the joints, in and around the joints, mechanical problem, not a disease actually. It is a phenotypic variation.
Due to contractures, sir?
Not contracture, slightly opposite, diametrically opposite to that. A lax
hyperlaxity. Hyperlaxity.
Very good. What is that syndrome called as? Hypermobility ligament
Syndrome.
laxity syndrome.
Syndrome.
HMLL syndrome. What was Vengit? What was the previous name of that complaint? During my PG days, etc., before I read regarding HMLL, I also had that impression that came under growing pains. It is one of the causes of growing pains. Where, Vengit, can you tell the reason for the growing pain caused by the ligament laxity?
So because the muscles are getting increase in size, and simultaneously the bones are getting increased, so that causes a growing type of a pain, sir.
Now the thing is, Venkat, the ligaments are loose around the joints. So what happens is that the muscles have to overwork. Suppose a ligament laxity child and a normal ligament tight child walks together 100 meters, it is as though the other child has walked 300 meters. You understand, Venkat? The same distance both walk. But because the ligaments are not doing their job, the muscles have to overwork. It is like in an office, a clerk works very efficiently. The other two clerks are doing extracurricular business. So every file comes into the other clerk and he's overworking and he becomes tired. So lactic acid accumulates and produces the growing pains. So let me ask that other guy, Vengit, other than Vengit, one more guy is that Gaurav. Gaurav, can you tell some of the associations of hypermobility ligament laxity syndrome other than the fall?
One is the Marfan syndrome, sir, yes.
You understand the elastic things like the Ehlers-Danlos, Marfan, etc.
Yeah.
No, I'm just asking regarding a normal child with a ligament laxity, hypermobility ligament laxity, not a syndromic or genetic. I see these cases commonly in the neurology OP. Lot of neurological presentations for this condition. But I am asking some of the things you might have noticed during your tenure in the PG life, like these children. What are they prone to? They are also prone to that back pain. Then they are prone to tension, headache, or migraine. And they are also prone to recurrent abdominal pain. What is that called? Irritable bowel syndrome, IBS. So this ligament HMLL syndrome is not a simple thing. It has got association with back pain, leg pain, then headache, irritable bowel syndrome, etc. If you ask them the questions, you will get one by one. All the children will not be having all the problems. Okay. And now let us come back to that Arathi. Let us come back to Arathi. Arathi, I told you that case, which was diagnosed as a complex musculoskeletal or complex muscle dystrophy by other people. Actually, I could they came with crying, but I could make them reassure because it was that child was having severe laxity. You will not believe that the genu recurvatum was so high. You understand? So because of that, he could not immediately adjust his muscles due to postural changes, and because ligament support is very much necessary for preventing falls. Okay, so that is ADHD with the hyperlaxity of ligament. Now let us come back to falls, the category that we are discussing. Falls without loss of consciousness, without vertigo. The first analysis has been done by Divya, not Aradhya. Aradhya has done the first, that is visual defects, she has said. Now, second thing I will give you, that is weakness. Second
Yes,
thing
sir.
that you have to think about is weakness, which is true in this case, isn't it? Arathi,
sir.
that is
Yes, sir.
weakness is the problem in this case. When you analyze the symptoms, you find that it is weakness. Okay. Now, in the weakness, also weakness, other than weakness, let us take any other problem which can cause recurrent faults other than weakness.
Yes, sir. In case of any incoordination or imbalance.
Very good. Ataxia.
Yes.
So you can definitely say in the exam, sir, there could be incoordination or ataxia. So any other thing other than weakness and ataxia which can cause recurrent faults?
Seizures, sir.
So no,
Seizures and
that actually we discuss with the faults with the loss of consciousness.
Oh, okay, sir.
Okay. So by any other thing, like you are concentrating only on the motor domain. You have told two
Sir,
axes of the motor system.
The peripheral neuropathy, like neuro
Very good.
sensory.
Very good. Thank you very much. Very good. But the thing is, Arathi, you should just before that, you should. I will tell you this thing. How CP is classified. CP is say what is the most essential criteria of CP? Can you tell? CP is the most common case that could be kept for your exam. That is why I am asking. What is the most essential criteria in CP diagnosis which distinguishes CP from mental retardation, developmental delay, autism, behavioral disturbances, developmental language disorders? What is it that differentiates CP from epilepsy, mental retardation? Everything looks alike, isn't it? And what is the most essential criteria that differentiates CP from all the other differential diagnoses?
It is static.
No, that is the commonest. See, don't take it in a bad way. Okay, don't say it is Pedanum or anything. The thing is, this is the most common answer that I get from my PGs here, MD PGs. They all of them make the mistake of static encephalopathy. It is not that. CP, see, the clinical features of CP are not static. The insult alone is static. The insult which caused the CP is static. So that is not the most essential clinical criterion distinguishing CP from other things like mental retardation, epilepsy, then this autism, all those things which look alike. Venkat, Ardi, I will just switch over to pass on to Venkat. Venkat, can you tell? I'm slightly deviating from the topic, but this is essential for you.
So motor
If possible, I will take a CP class later for you. But this is just yes, correct. You're right. Motor system.
motor involvement.
Correct. You should say in the exam that it's a motor system disorder. CP is the motor system is affected. Then I will ask Gaurav. Gaurav, what are the three divisions of the motor system? The most important three divisions, even though there are subsystems.
So the power, the tone.
You are actually, Gaurav, you are actually taking the examination of the motor system. I'm not asking that. I'm asking the motor system, the three components, the three most important components of the motor system. If you know only, you can go about the false case, analysis of the false case. This false case is not a very simple case. It has got its own complexities. So motor system is divided into three major things. That is pyramidal system. What does it do? Voluntary activity. Okay. That is associated. The pyramidal system is associated with the power. Okay. Then second is the extrapyramidal or basal ganglia system. And third is the cerebellar brainstem connection or the cerebellar system. So that is why we divide CP also. Spastic CP, dyskinetic CP, attack CP. So let us come back to this case where she has said weakness, visual problem, weakness, ataxia. And then comes the movement disorders. You should also think of movement disorders when you discuss recurrent faults. Okay. Okay. I hope you understand. Aradhya, I'm sorry.
Yes, sir.
Aradhya, you understand that
Yes, sir.
recurrent faults could also be caused by paroxysmal dystonia, involuntary movements. Like, for example, paroxysmal dystonia is one condition which can come and cause recurrent faults. Whenever that child tries to walk, that is, the foot goes into dystonia and he falls like that. So there can be kinesiogenic dystonia or non-kinesiogenic dystonia like that. Now, Aradhi, that is, so you understand when we analyze for recurrent faults, when we are taking weakness and ataxia, you should take one more thing. That is the movement disorders. Now let us come down to the come down to the other things. Like you said, Aradhi herself said, peripheral neuropathy, sensory loss. It's very good, Aradhi, very good. Sensory loss can cause faults, isn't it? Especially especially when the other sensory empowering phenomena like vision is also affected. A person with peripheral neuropathy is more likely to fall than a person without peripheral neuropathy. And also, like you said, feet abnormalities can lead to recurrent falls. In that, there is an addition here. See, it need not be sensory peripheral neuropathy. It can be motor peripheral neuropathy also, isn't it? Can you tell the classical symptom complained by hereditary motor sensory neuropathy children when they begin to fall initially? What is that symptom? Rajesh, I will ask Rajesh. Rajesh, hereditary motor sensory neuropathy children, when they begin to fall, they will first complain of one aspect. They do not fall in a particular surface, but they tend to fall in a particular surface. That is what Ari has written in the initial part of the presenting complaints. When we read that, we think that, oh, is it distal? We tend to think. What is it? Rajesh?
Don't know.
That is
escape from
uneven.
injury.
Rajesh,
He may
you notice.
try to escape injury.
No, Rajesh. You just read the initial part of the Ari's second slide. You get that complaint, especially on uneven surfaces. You understand? Frequently fell while walking, especially on uneven surfaces. That uneven surface thing and the even surface thing matters mainly to distal weakness. You understand? Distal weakness. So from the history of presenting complaints, we got the localization possibility of a proximal weakness condition, isn't it? We never thought of a distal. But here, there is one point in the that is favoring a distal weakness. But it need not be distal weakness. It could be something else also in the distal part. Like Aradi said, some abnormality like pes cavus, flat feet, or other deformity can also lead to more chance for falling in the uneven ground. Why uneven ground? This hereditary motor sensory neuropathy persons tend to fall more often in uneven ground. What is the reason? Venkit, I am coming to you. Venkit, the most important PG here. Venkit, say, what do you say? What is the reason for the mechanism of fall, especially when a hereditary motor sensory neuropathy child walks on uneven surface? Just a thing. So let me tell you, in our MBBS, okay, we study buckling. Okay, buckling. Then tripping. Tripping. In MBBS, remember hemiplegia? Because we take MBBS, buckling, tripping. There is one more mechanism of falling that we tell. No history of any buckling, no history of any tripping, no history of any stumbling. Stumbling is the mechanism of falling, mainly in case of a distal weakness. Even though tripping can also contribute. Stumbling, you understand? Stumbling is we are falling on the angle. The angle is twisting and we are falling. Why? What is the reason? Because the anterior compartment muscles and the peroneal muscles are not acting properly. You understand? To stabilize the angle joint. Okay. Then that is we have actually come to peripheral neuropathy that was complained by Aradi. But when we came to the sensory loss associated with peripheral neuropathy, we remembered that the motor problem associated with the peripheral neuropathy can also cause falls, especially in the beginning on uneven surfaces. Okay, sensory loss because we are not able to correctly find out the surface texture and pressure. We tend to fall. Then, is there any other mechanism of falling in the sensory variety other than peripheral neuropathy? Aradi, any other mechanism, any other sensory problem which can cause, other than the vision, which can cause recurrent faults? I will give you a clue also later on when you are thinking.
The posterior column.
Very good. Correct. That is called a sensory ataxia. Aradi, let me ask you one question, which many of our PGs do wrong. That is, how do you test sensory ataxia? What is the basic difference when you test sensory ataxia and when you test cerebral ataxia? What is the basic difference?
The Romberg sign is used to test the posterior column sensations of a sensory ataxia.
And cerebral ataxia is tested by? Gait ataxia tested by?
The child should be standing with stands with a wide stance and with eyes open.
Okay, you are actually telling regarding the walking pattern of an ataxic child. The child usually Agarsh has written a message. It just came and went. Agarsh, I could not see that message. Agarsh, can you tell what
Sir,
you
we should, while testing for dorsal column, we should close our eyes.
very
While
good, very
testing,
good. That is the point. That is for posterior column. When you are testing, we should close the eyes. Why? Because what is the mechanism, Agarsh? Why we are closing the eyes? That's a very good answer. Very good. For cerebral testing, what do you do, Agarsh? What do you do? Cerebral testing, we have to keep the eyes open.
eyes open and then do the same procedure.
Do the almost the same procedure with both the feet close together. You have to stand. In sensory ataxia also, when we test Romberg, we ask the patient to stand with the feet close together. But when the eyes are open, the patient does not fall. So when the eyes are closed, the patient tends to sway and fall. So what is the mechanism? How do you why are you closing the eyes while testing for the sensory ataxia?
Sir, for the proprioception, joint proprioception.
Can I ask in a different way? That is, 90% of our sensory input is visual. Nowadays, our reading is also less, and mainly we are depending on the digital media. Everything is visual. But the thing is, visual is a very powerful sensation, I understand. But because Gaurav is an inquisitive person, I'll ask Gaurav. Gaurav, what is our blind vision? What is our blind vision? Even when we are in the dark, we know where we are and we can move about. What is that blind vision? What is the tract that subserves a very powerful tract, fast transmission, one of the fastest transmissions in the body, which protects us from dengue fever also. That tract protects us from dengue fever. What is that tract? With the highest rate of transmission, equivalent only to somatic motor nerves. What is that transmission path? That Aradi has said it previously, just a few minutes back, she said that name of that column. What is that, Gaurav?
Not sure, sir. Dorsal column.
Aradi is giving you telepathy. You look at Aradi's face. She was giving lip reading capability. That is posterior column. Posterior column is our blind sight. So you understand, Gaurav, that is posterior column. Even when vision is not there, the posterior column is the one that helps the blind people to go about their daily activities and other things, especially in addition to hearing, the hearing problem. Like in Mohanlal uses the hearing techniques in Yoda. You understand? When his vision is gone, his hearing becomes very sharp. So like that, posterior column is the blind side. So the mechanism why we are closing the eyes to test the posterior column is because where is the processing center for the coordination? That I think if Divya, if she has come back and answer, or when it can answer. What is the processing center or the central computer for coordination? The motor computer of the brain. One of the fastest transmission lines inside. What is that?
The cerebellum.
Very good. Cerebellum. Cerebellum is the motor computer of the brain, the main motor computer. So the thing is, cerebellum is the processing center where all the sensory impulses are reaching. You understand? The visual sensations reach from the superior colliculus and the other thing. Then the other thing, that is the posterior column reaches. The cerebellum has more direct pathways, right? Like the spinocerebellar tracts. The posterior column on the way actually gives off collaterals to the cerebellum. The sensory information from the parietal lobe can also reach the cerebellum through the corticocerebellar tracts. So from everywhere, cerebellum is getting the information. It is processing the information. When one of the arms of the afferent arm is defective, cerebellum adjusts with the other arm. You understand, Gaurav? That is, cerebellum is adjusting with the vision when the posterior column is gone. But when the visual input is taken away, the posterior column abnormality manifests. So, Rajesh, I will ask, Rajesh, what is that sing sign that we commonly ask regarding tabes dorsalis persons or persons with the posterior column problem, they tend to have a sink sign. That's a funny thing only, sink sign. Sink means water sink, or wash basin.
Sir, while
That's
we
you can
close
say.
our eyes, the moment we close our eyes while washing our face, there can be a loss of balance. So we
And
call
then
it in
suddenly
the
our forehead will go and hit the mirror
wash
or the
basin sink.
thing, wash basin or mirror, whatever it is, and we'll get an injury. Okay. Another thing is current cut sign. That is, we say funny because during when the current goes, suddenly we hear the sound of a fall. That's in the case of a posterior column. So let me ask one funny question. Funny question to anybody can answer. That is, how does the posterior column protect us from dengue? Posterior column or the large myelinated afferent 1-alpha sensory fibers. How do they protect us from dengue fever? And what is the mechanism? That's how I will not take much time because we are all very hungry also. The thing is, as soon as the mosquito lands on our skin, we know by the fine touch mechanism. And suddenly we kill the mosquito. If you don't kill the mosquito will bite and the dengue virus will be transmitted inside. So even before the pain transmission comes to the voluntary, that's conscious cortex, the mosquito's landing comes to the conscious cortex. You understand? That is the difference in fastness between the two tracks. Okay, now let us stay. She has very good said all the answers. Arathi is very good. This sensory ataxia also she said. So okay, can you tell one example of a backward fall that we see in certain children between the 5 to 15 age group? Backward fall. Suddenly, I will tell the example. Suddenly, the child falls backwards as though, or child or adolescent can also fall. As though somebody has catched on his collar. Minal Muraliile collar pidichu valikule, scene bola. Then suddenly somebody pulls him from the back. What is that type of fall? In what condition that fall occurs? A common condition, all of you know. It does not have any treatment up to now, except one medicine which may slightly prolong life. It manifests with academic deterioration. Now you tell.
So absence issues.
Very good. One of the differential diagnosis of academic difficulty. A very good studying child going into academic difficulty, that is a completely different topic. 20 differential diagnoses are there. That I'm not going. That one of the things is what you said is correctly, Adira. That is a absence issue. But more commonly, a child who was studying well now develop academic deterioration initially. Then he develops sudden jerking of the limbs. Yes, Ashwati has given answer. Thank you, Ashwati. That is SSP. In SSP, there is a sudden backward myoclonic movement which leads to tendency to fall backwards. Also, somebody has pulled you from behind. Okay. Now where were we? We deviated from the topic a little. So that is, we were analyzing the various mechanisms of recurrent falls without loss of consciousness and without vertigo. That is, we analyzed weakness, ataxia, movement disorders, then sensory loss of two types. That is peripheral neuropathic sensory loss, sensory ataxia. In addition to that, when we came down to the localizations, we can also tell, just like the muscle can cause proximal, anterior horn cell involvement can also, juvenile SMA can cause proximal weakness. So in the weakness, when we come to the lower motor neuron, there are 4 localizations. That is, we discussed the things in the upper motor section. That is anterior horn cell, nerve root, neuromuscular junction, and muscle. 5 localizations. Nerve root, because that is condition is not very common in our setup, but in adults there is condition called CADP and all that, where the nerve roots are preferentially involved more than the nerves. So there are all variants of DBS in a sense. There also we can, but that is not DBS is not a long-standing condition. It's an acute condition. So that is why we are not discussing that. But in the anterior horn cell, we can have juvenile SMA. In the nerve, we can have hereditary motor sensory neuropathy. There also, the hereditary motor sensory neuropathy children falling will be initially in uneven surface. Later, they can have walking difficulty, but usually it progresses very slowly. And then comes the Okay, then then comes the neuromuscular junction. Any condition in the neuromuscular junction disorder which can present similarly, taking a longer time. Because neuromuscular junction, what is the disorder? Neuromuscular, most common is
myasthenia gravis.
myasthenia gravis. What is the typical site of involvement of myasthenia? That is
Postsynaptic receptors.
no, madam. That is the ocular
Okay,
involvement.
okay.
So that is
Okay,
why
sir.
we don't never consider myasthenia in the differential diagnosis when we get a presenting complaint like this. But there is a rare condition which can present like that. That's called limb-girdle myasthenia, where initially it appears like a LGMD, but later on the ocular involvement and generalized involvement can come. Okay, then comes the muscle. Now that is what you are actually pointing to, muscle. Okay. Now I will allow you to continue with your presentation because I have taken a lot of your time. Okay. In between, you want to drink something also, you can drink after closing the video. Okay.
Okay, so I will continue with my presentation. History of
Okay.
present illness. A 10-year-old boy was apparently normal until a year ago when caregivers noticed that he frequently fell while walking, especially on uneven surfaces. These symptoms were not associated with any loss of consciousness or abnormal movements. The symptoms were initially dismissed, but later the frequency increased. Child developed significant difficulty in climbing the steps of his school bus. Noticed 8 months back, he began relying on the side rails for support, and he had to kneel on the steps to climb up.
One interruption, one more interruption. After that, I will stop. The thing is, when you are saying regarding the fall, you said regarding uneven surface. That is that I accept. In addition, you had to ask the mother how he fell. That is very important. That's a mild detail in the analysis of the fall is necessary. That is uneven surface. I agree, but in addition, you should ask the mother whether he fell sideways.
Okay.
Sideways, that indicates ataxia. Whether he fell backwards, that could be due to negative myoclonus or other things that I told. Whether he tended to fell with the buckling, that is, you should ask regarding buckling at this stage, not when you come to the climbing stair difficulty, because climbing stair difficulty everybody knows is due to proximal muscle weakness. That could be due to other causes, but you should ask whether the child suddenly fell by അതിന് നമ്മൾ മലയാളത്തിൽ ഉപയോഗിക്കുന്ന ടെർമിനോളജി കൊഞ്ചി നമ്മുടെ ഇവിടെ ട്രിവാൻഡ്രത്തല്ല കൊഞ്ചി വീണെന്ന് പറയും. അതായത് മുട്ട് മടങ്ങി വീണു. മുട്ട് മടങ്ങിയാണോ അമ്മ വീണതെന്ന് ചോദിക്കണം. അത് കഴിഞ്ഞ് അന്ന് ചോദിക്കണം അമ്മ വീഴുമ്പോൾ എപ്പോഴും അവൻ ഇങ്ങനെ കാല് നേരെ വെച്ചിട്ട് കാലിന്റെ അറ്റത്ത് വെച്ച് മറിഞ്ഞങ്ങ് പോകുന്നതാണോ, അല്ല വിരൽ വന്നിട്ട് തറയിൽ ഇങ്ങനെ വിരലിന്റെ മുകൾ ഭാഗത്ത് വല്ല ഒരഞ്ഞതിന്റെ ലക്ഷണങ്ങളോ വല്ലതും ഉണ്ടോ എന്ന് ചോദിക്കണം. ഇത് നമ്മൾ യൂഷ്വലി ഹെമിപ്ലീജിയയിൽ ചോദിക്കുമെങ്കിലും ഇതിലും ചോദിക്കാം നമുക്ക്. Okay, and also you should while analyzing the fall, you should also ask the mother whether there are any complaints like lack of sensation below a particular level or like bladder complaints also. When you are saying regarding fall, you have to tell some of the symptoms of the other localizations also. But after that, you can immediately go to the next complaint and analyze it. Okay.
Over the past 8 months, difficulty has worsened, necessitating the assistance necessitating nearby assistance and more time to ascend stairs with a high rise. Consequently, he resorted to using a rickshaw as an alternative mode of transportation to school. In the past year, his physical activities, which involved a wide range of movements, as well as his outdoor play with his friends, decreased significantly along with the progression of his symptoms. Additionally, the child experienced considerable difficulty rising from a squatting position or sitting position on the ground, requiring support from...
Can I interrupt 1 minute? That is, I got a point from the previous slide. Can you show just the previous slide? Fast attainments and this one, very good. High rise thing. The second one, next one. It is high rise. Consequently, he resorted to using a rickshaw as an alternative mode of transportation to school because he was finding it very difficult to climb the stairs of the bus, isn't it? Okay. Now, let me ask a side question to another, that is maybe Agarsh, I will ask. Agarsh, this, you have 2 children, okay? 2 children in the age group, maybe like 6 years, okay? One child, two brothers in the same family. One child actually when they are subjected to a running race or this thing, one child actually runs, the other child walks. Okay, same age group. Then one child, when asking to go to some place with the mother, the one child can take the steps, and I mean they can go in the bus. The other child says, I cannot go in the bus, I will go with an auto. What is the congenital condition? Not this is an acute condition. This is not a congenital condition. What is a congenital condition that of the muscle which can produce such a scenario where the child underperforms in comparison to the peers in strength, muscle strength? The other child can lift 5 kilo. This child can lift 2 kilo. What is that condition? It is one of the good conditions in congenital muscle conditions. What is that condition called?
Central core myopathy.
Very good, very good. That is congenital myopathy. You can say congenital myopathy. The central core, everything is pathology things, because there is a lot of phenotypic variations. Even though you say one type, Nemaline rod can have ptosis, need not have ptosis. So you can say congenital myopathy is a very good condition among the muscle conditions presenting with a floppy baby in infancy and later on leading to isolated motor delay. So it's one of the conditions presenting with isolated. So this see the floppy thing, then in later life will lead to isolated motor delay. So the isolated motor delay child having the same, when compared to the same age group children, has less strength when compared to the other children, but he still can do some of the normal activities. Okay, now Arathi continue.
Okay, sir.
Arathi, what
Additionally,
is the time up to which you can present? That is 9 p.m.
Yes, sir.
Okay, so I am not interrupting you. Only if
Sir.
very important, I will interrupt.
Okay, sir. Additionally, the child experienced considerable difficulty rising with squatting position or sitting position on the ground, requiring support from the ground to rise to a standing posture. He could sit comfortably on the ground, but when attempting to rise from the ground position or from squatting position, he first kneels down and then uses support from the ground with his hands to gradually rise to a standing posture. As a result, they took him to a hospital where he was diagnosed with bilateral flat feet. He started using parrot insoles.
What is that difficulty? What is the major muscle group that is behind, that is weak, that is causing him this difficulty of rising suddenly from the this thing floor without using his hands? He can kneel. After kneeling, when he wants to get up, he needs to use the upper limbs pressure he has to apply on the ground, and then either he suddenly applies a pressure and suddenly tries to elevate himself as though a person is rising with back pain. Some back pain people, because they are afraid the back pain will worsen, they will actually push on the ground so that they will get the reaction, so that the spine will straighten. So what is the group of muscle causing that difficulty?
After kneeling down to get rise, the erector spinae muscle are
very good. The erector spinae muscle, that means the erector spinae muscle are weak. Okay.
Now he started using parrot stoles, but the symptom persisted. The caretakers noticed a recent clumsiness in his posture, as well as he gained a weight of 4.5 kg over the past 1 year, and also noticed that he had difficulty in getting up directly from the bed after a nap. To rise from lying position, he had to turn on his side and use support with his elbow and arm. There was no difficulty in rising from the chair.
So what does that complaint mean? That is the previous slide. We will just in the way is also as important as the end. In many cases, Arathi, in many cases in DM case presentation also, even after the case presentation, both the professor as well as associate professor and assistant professor, they cannot reach a diagnosis sometimes. But still, the discussion itself is very important, because that is why I'm interrupting in between. So that is from where we get the points. That just like we say in the monk who sold his Ferrari book, the way is also equally beautiful as the end. So the thing is, caretakers needs difficulty. He had difficulty in getting up directly from the bed after a nap. Gaurav, can you say a reason for that? He had to turn on his side, use support with his elbow and arm to rise. What are the muscles implicated, Gaurav? Can you tell from that complaint? I'm very happy that Gaurav or Ragesh Agarsh are there, because the other two were absent. These people are helping me tide over the crisis.
So proximal muscle weakness is more likely.
Which one, Gaurav? That is rise. Gaurav, you are lying on the bed. Okay. Your mother is calling you. Suddenly rise from the bed. Your upper body is suddenly rising from the bed. Your buttocks are planted on the bed. Buttocks and the legs are planted on the bed. You suddenly rise, and you place the legs on the side of the bed, and you rise up and sit. So what are the muscles doing that? helping with that. Three
So in-
group of muscles.
For the standing position, sir, gluteus maximus is the
No, not the standing position. You are lying on the bed. Suddenly, in the night, somebody is touching, like in a horror film. Somebody is suddenly touching. You suddenly rise from the bed. So what helps you rise from the bed quickly? This person is finding very difficult to rise from the bed suddenly like that. That is, one is the abdominal muscles.
Rectus abdominis.
Rectus abdominis and the corresponding other obliques and
iliopsoas.
other. But the main muscle, another main muscle is the iliopsoas.
Iliopsoas.
Okay, iliopsoas. Okay. Then actually, I will tell you one thing. I consulted my Dr. Susan Udup's madam's husband is a very expert sports therapist actually. So I was actually doing this Meru Dandasana to reduce the abdominal fat. Meru Dandasana involves raising both legs at right angles to the body. And even before Meru Dandasana, I was doing that Bhujangasana. So when I had some difficulty in the spine after doing, so when I consulted him, he said, doctor, don't do with this weight of your legs, don't do the Meru Dandasana, because when you're rising like the legs or when you're suddenly standing up, it is the iliopsoas that is working. So the iliopsoas will pull on the spine and cause spinal problem. If your spine is not strong, first we have to strengthen our core spine, then only do exercises like Meru Dandasana. So that is a very good lesson. That is, this boy is not having weakness of the iliopsoas, the proximal muscles which are controlling the hip flexion, which are attached to the spine, and also the abdominal muscles, and as well as there is one more muscle which helps with the sudden rising, that is neck flexors. But I am not saying that the neck flexors are weak. I am just saying that the iliopsoas and the abdominals may be weak. That is why he's turning to the side and rising. Okay, Arathi, continue.
There was no difficulty in rising from a chair, kicking a ball, or climbing stairs with a short rise. There was no history of slipping of sandals or dragging of foot while walking. He had no difficulty lifting arm above his head, combing his hair, buttoning or unbuttoning, or tight hold of objects in hand. No history of tingling, numbness, or paresthesia, or band-like sensation or back pain. No history of frailness, stiffness, swelling of limbs, or muscle cramps or pain. No history of...
Venkat, Venkat, can you respond?
Sir.
You are my only solace. That is, see, the thing is, no difficulty from rising a chair, kicking a ball, etc. She's saying, and no difficulty lifting his arm above the head, combing his hair. You are understanding the implications of all this. That is, there is no. She's meaning no proximal weakness in the
distal
weakness in the upper limb. Okay, and even rising from a chair, actually, it may be a light difficult, but he will adjust, and because he is at a much better position than the squatting, he will adjust. But later on, that also will become difficult. Now, no history. The other things that she's saying, like no tingling, numbness, all this you are understanding. Okay, okay. If any difficulty, you can just ask her what she means by this thing. Okay, okay.
Okay, sir. No history of symptoms of changing throughout the day or easy fatigability. No history of loss of consciousness.
Okay. By that, what do you mean? The no history of symptoms changing throughout the day or easy fatigability. What are the differential diagnoses coming into your mind when you say that?
So the neuromuscular junction disorders.
Yes, myasthenia, and anything, one thing more.
Metabolic
not in this setup, but I mean, it can happen in this setup also. But it is not that much associated with the proximal thing. That is called the Segawa syndrome. Segawa syndrome also has got diurnal variation. Okay. That is dopamine responsive dystonia. Okay, this easy fatigability, that I understand. That is a symptom of this myasthenia. Then let me ask one side question by the side. That is, Ragesh, what is the nature of the reflexes in myasthenia, deep tendon reflexes?
Yes, preserve, sir.
Ragesh? Okay, then I will ask that other person, Gaurav, what is the nature of the deep tendon reflexes in myasthenia?
Since there's a neuromuscular junction is involved, sir.
So what is the nature? Is it increased, decreased, or normal? What do you say?
Sir,
no, I appreciate, because you are contributing in the position of Divya, I will buy you a present. I will send you a present through Amazon. So the thing is, you just send me your address through Thomas. Okay, I will send you a present because you are very helpful.
Sir, I'm not sure, but I guess the areflexia will be there, sir.
No.
So
That is
Flexus will be normal.
the standard condition. Two things are spared in myasthenia. One is the
Sir.
pupil. Pupil is spared.
Reflexes.
Pupil is spared in myasthenia, and the deep tendon reflex are spared in myasthenia. But suppose Rajesh, thinking that it is like that, and you are taking advantage and you are hitting again and again and again, then the reflex may decrease because the neuromuscular junction is slightly failing. The muscle is failing to contract properly. But when you are hitting 1 or 2 times or 3 times, maybe the reflex will come. So let me ask you one side question to that. Arathi, the other two
Yes, sir.
people are not there, isn't it? Divya and other people are not there.
No.
So we cannot ask them ghost questions. The thing is, what is the, how do you grade the reflex in case of a dystonic CP? This is a side question to raise your awareness that such questions are possible in exam. Dystonic CP, how do you grade the reflexes? I mean, what is the reflex you get in dystonic CP?
So 4 plus with the pronus.
Okay, you just stand there. I'm putting that answer on the side. Now I will ask Venkat. Venkat, what is your opinion? Dystonic CP. You people definitely need a class on CP. I'm not saying you can have the class from Mary Madam or Mohammed sir, whatever it is. Somebody experience should take a class for you because CP, many things you are missing. But that is not a, I'm not saying it is a defect. Please don't misunderstand me. All our PGs are also like that. So there is no difference between the PGs in Trivandrum and the PGs in Kottayam. And they are also saying much different. So Venkat, can you contribute?
So there may be high, like normal reflex, 2 plus.
Very good, Venkat. Thank you very much. I got a relief. That is, it is normal or sluggish reflex, as in the case of a normal patient. And can you tell the reason why? In dystonic CP, you know the tone is increased, rigidity is there, dystonia is there. I understand. But still, the reflexes are normal or sluggish. Why I am saying sluggish is not as in a pathological manner. In children, Venkat, in children up to 2 years, usually the reflexes are very difficult to obtain, except the knee jerk that is well obtained in most children. Even in newborns, etc., and other things also you get the knee jerk well, but you don't get the other reflexes. When you examine normal children in the ward, you should make it a habit to take normal reflexes in respiratory infection children lying in your ward. You understand? You should know the feel of the normal to understand the abnormal. So that please make it a habit to take the reflex, carry a knee hammer, velour knee hammer. It's very effective. And try to get the reflex of normal children, cooperative children in your ward. Especially you start from the jaw jerk, the biceps jerk, triceps, everything you do again and again, you will develop a very good skill in taking the reflexes. Okay, so this actually in children less than 2 years, comparatively reflexes are sluggish. But in dystonic CP, sluggish is a normal thing only. That is normal or sluggish. What is the reason is because time is running. I will tell the reason. See, I have got a side question for Gaurav. Gaurav also is very good. So Gaurav, sorry for asking. The thing is, you tell me the 3 different systems controlling power, tone, and reflex. There are 3 different systems: power, tone, and deep tendon reflex.
Sir, power is controlled by the cerebral cortex, sir.
No, you should tell in the exam pyramidal tract.
Okay. Yeah, sir.
Pyramidal tract. Power is by the PP.
Yes,
PP.
sir.
Power is by the pyramidal tract. Okay.
So,
Now, tone is controlled by what system? When we have studied in physiology, one sentence we can say.
Tone is extrapyramidal.
No, that is wrong. Tone is sorry for saying that it is wrong. Tone is controlled by the gamma fusi motor drive. That is what Sushila madam taught me in the physiology in MBBS. I still remember her saying like that. Tone is controlled by the gamma motor neuron. Even though there are, see, you understand. Anterior horn cells are concerned with the power because the corticospinal tract is supplying them either directly or through the interneurons to produce certain movements as well as actions. Okay, the actions are integrated in the cortex. The movements are carried out by the anterior horn cell, lower motor neuron. But tone actually, various tone controlling influences which are enacted through both the cortical pathways, the basal ganglia and its output tracts, as well as the cerebellum and its output, and all the things controlling tone. The tone controlling pathways are many: vestibulospinal, tectospinal, ubrospinal, then reticulospinal. There are 4 reticulospinal tracts. 4. So there's a cortico-reticular spinal tract. All these are controlling tone. There's an anterior corticospinal tract controlling axial tone. So the thing is, all these are actually impinging on the gamma motor neuron. You can draw the gamma motor neuron as a large spindle muscle fiber, large spindle neuron on the top of which multiple positive and negative influences are impinging. That is actually the end result of that is actually controlling the tone. You understand? So when the basal ganglia are damaged, the increased tone is mediated because the abnormal circuitry in the basal ganglia gives out an abnormal signal which activates the cortex generally, causing a dystonia or a rigidity. You understand that it is not the basal ganglia alone that is controlling the tone. Multiple influences are, not only basal ganglia. So what about the reflex system? What is deep tendon reflex different from this? How is it different? That is, deep tendon reflex is a monosynaptic pathway. Monosynaptic pathway. We only need to think about one cell, that is the anterior horn cell. So what is the one organ in the motor system which actually enhances the sensitivity or the irritability of the anterior horn cell? Is it basal ganglia or something else? One positive. A slight positive increase in tone as well as reflexes is mediated by one organ that we discussed previously, the motor computer. What is it? Cerebellum. Cerebellum alone has a positive influence on tone and reflexes mediated at the anterior horn cell level. You know how we can suddenly increase the tone all over our body, especially the paradoxical head lift of a cerebral palsy child with a hypotonic face. When you keep in ventral suspension, suddenly the child assumes a Hanuman posture. Hanuman flying to Langa with the Mirta Sanjeevani and all that. That posture suddenly comes because of the vestibulospinal tract. How does it act? It just stimulates the gamma motor neurons everywhere. You understand? The gamma motor neuron sends impulses to the muscle spindle. The muscle spindle becomes tight. Once the muscle spindle becomes tight, the nuclear chain and the nuclear back fibers produce impulses in a high volume, leading to further activation and increase in the extrafusal muscle tone. You understand? Extrafusal and intrafusal. Please read regarding tone before the exam, because some of the points, because the pediatric examination are also very strong in tone and all that. They will ask. Okay. Now, I told regarding the 3 systems when we deviated from the deep tendon reflexes thing. So tell me regarding the tone and reflex in chorioidal CP. One more question from CP. After that, we'll come down to this thing. Tone and reflexes in chorioidal CP. And anybody can tell. Gaurav, type anything. There is hypotonia in chorioidal CP. Hypotonia in contrast to dystonia, and the reflex are just like dystonic CP. That is normal or sluggish reflexes. There is no decrease in. See, you understand that a child, a floppy infant having hypotonia. Floppy infant is a infant does not mean that the reflexes are going to be down. There can be increased reflexes in a hypotonic floppy baby. What is the condition? Increased reflex in a floppy baby. That is hypotonic phase of spastic CP. That is where the paradoxical head lift occurs. Likewise, you can have hypotonia with the normal reflex and normal strength in a floppy baby. What is that condition? Hypotonia with the normal reflex and normal strength. A benign condition, which begins with the benign. Benign infantile hypotonia. Okay, we'll come back. Arathi, you continue.
Okay, sir. No history of loss of consciousness, memory loss, speech difficulties or behavioral changes. No history of visual disturbances, drooping of eyelids, abnormal eye movements or squinting. No history of abnormal facial sensations, difficulty in closing eyes, drooling or difficulty drinking with a straw or loss of taste sensation. No history of difficulty hearing, swallowing dysfunction or aspiration of feeds. No history of difficulty in turning head side to side or shrugging of shoulders. No history of deviation of tongue or abnormal tongue movements. No history of any involuntary movements or cognitive decline. No history of any bubble or bladder symptoms. No history of deviation of tongue to one side while walking. Yes,
Arathi,
sir.
can I ask you one question, one direct
Yes.
question, simple question only?
Yes, sir.
In certain conditions, we in GBS, we tend to, in GBS, Guillain-Barré syndrome, it's a lower motor neuron condition where we tend to check the strength of the facial muscles because bifacial palsy or unilateral palsy can be associated with the, usually bifacial can be associated with the GBS. It need not always be associated. So how do you go about testing the facial in that condition? Other people can help also.
Sir,
You just close the eyes and look, or you do something
no,
else.
no. I'm looking for the tight eye closure and
Very good, very good.
eye
You,
opening.
Chandra madam told me like this. Soap veena madiri kannadakingo. Madam, I still hear the words inside my brain. That is soap veena madiri kannadakingo. One more thing that she told me that has always helped me. I will tell you. That is listen to the patient and he will give you the diagnosis. Or the listen to the patient or the bystander. In the case of us, it is bystander. Listen carefully. The bystander himself will give the diagnosis. That became true in a dystrophy case. I will tell you a simple example. That an Opsal patient was there, 6 years or 5 years, and he came with a weakness, the same complaint, exactly same complaint, pseudo hypertrophy. That hypertrophy of the calf was there. So the diagnosis is obvious, isn't it? It is Duchenne muscular dystrophy. So I was writing the admission. This is several years back, 10 years or something. I was writing the admission for the patient for muscle bias. At that time, genetic diagnosis was not there in my PG days, and not PG, immediately post. So then the mother told me, sir, I have got hypothyroidism. Suddenly, something came inside me. See, I am just like Chandra madam told me, you always pray when entering your consulting room or hospital. Oh God, give me the diagnosis in my mind. Make me write the correct investigation and treatment and heal my patients completely and protect me from the bystanders and patients. Because you should always, the primary role is protect yourself. So that also is included in the prayer. Primordial protection of the person who is carrying out the doctoral activity. So the thing is that suddenly struck me something. What is that? What does that struck me? That diagnosis you can tell? Mother saying that she has hypothyroidism. Suddenly something struck me bad. In the CPK was elevated, pseudo hypertrophy is there, complaints are matching, but still
that's a hyperthyroid myopathy.
No, hyperthyroidism. Usually, the patient will be like becoming very wasted, tachycardia, palpitation, lack of sleep. This is the typical presentation of a Duchenne like or Becker maybe. So the 5 years, I think, if we remember correctly. So what is that condition which exactly mimics a Duchenne like phenotype?
Myotonic dystrophy.
Oh, that is no, that you are meaning Thompson. No, not that. The hypothyroidism associated with hypothyroidism. That syndrome. 3-word syndrome, three scientists' name. Oh, very good, very good. Rajesh correctly. Rajesh also said, Gaurav also gave the correct answer. So the thing is Kocher-Debré-Semelin syndrome. That was actually a Kocher-Debré-Semelin syndrome. I would have admitted him for the muscle biopsy, but God gave me the diagnosis. Immediately, that is the way. The bystander himself gives us the diagnosis. And it clicks. And when I tested, the TSH was 100. You understand? TSH was 100. We could avoid admission. We could. Then I contacted MKC Nair sir, and he gave me certain. He has got the highest collection of such kosher that hypothyroid cases. So I contacted him. Sir told me how to go about the case and treat and all that at that time. Okay. Now you can continue.
No history of muscle cramps or cola-colored urine or worsening of symptoms with intercurrent illness, exposure to cold during exercise or after having a meal. No history of any rashes or abnormal pigmentation. No history of recent fever, diarrhea, or recent immunization. No history of breathing difficulty, chest pain, or palpitation.
What are the group of conditions which are slightly different from our condition, but which cause like cramps and very much fatigue after even simple exercise? Example.
Glycogen storage disorders.
Very good. Myophosphorylase and other metabolic myopathies. Metabolic myopathies and mitochondrial myopathies or this glycogen storage and that is myophosphorylase deficiency, etc. Myoadenylate deficiency. All these cause tendency for cramping and also sometimes they cause rhabdomyolysis also. Okay, okay. That is correct only. Okay.
The past history, there is no significant illness in the past except a history of ALR at 1 year of age acquiring admission. There is no history of similar illness in the past also. Angelical history is the first child of non-consanguineous marriage, conceived at the age of 21 in mother and age of 30 in father. Regular ANC from the local hospital Kanjirapalli. First trimester was uneventful, dating scan was normal. Second trimester uneventful, no maternal comorbidities, anomaly scan normal. Third trimester uneventful, appreciated good fetal movements. Growth scan and late scan were normal and no evidence of polyhydramnios. And natal
Now,
history.
can I ask one question in between? That is a question pertaining to your exam only. That is, tell me, Gaurav, tell me 4 conditions which cause reduced or absent fetal movements in utero. And Venkit, meanwhile, prepare in the mind 4 conditions which cause arthrogryposis.
So the reduced intrauterine fetal movements, sir. One is the SMA, sir. Second.
Okay, you should say that fetal origin SMA. You should say like that. The normal SMA does not usually come out with contractures. You know, what is arthrogryposis? It is congenital contracture of joints. It is defined as congenital contracture of joints. So the normal SMA does not come out, SMA type 1. It is the fetal origin SMA that comes out. You should say like that in the exam. So what is the second condition?
Second condition, decreased amniotic fluid, sir.
Okay. Because the child cannot move about. Very good. That is another. That is a non-neurological. Okay. No, I'm asking regarding the neurological conditions because the same. Actually, the 4 conditions are. I asked both of you are the same. You understand? Whatever produces reduced or absent fetal movements in utero tend to produce arthrogryposis. The joints and the surrounding tissue develop only better when the movements are there in the uterus. When the movements are not there, the joints tend to go into a contraction. So tell me 3 more conditions. Which these 3 more conditions come under a floppy baby also.
Congenital myopathy.
Very good. Congenital myopathy. Then congenital muscular dystrophy.
The congenital myasthenia.
Myasthenia also you can do, no problem. But usually congenital myotonic dystrophy is more. Even though congenital myasthenia also Fenichel says. Okay, that is okay. Because the thing is, why? Because you should say that the severe forms of you can say the severe forms of congenital myopathy, congenital muscular dystrophy, congenital myotonic dystrophy can present with a complete reduction or almost absence of fetal movements, leading to arthrogryposis at birth. Because these conditions can present like that, or they can come out just out of the uterus. When they come, they can lead on to bradypnea, apnea, feeding difficulty, etc. Or they can present a little later on also. Let me ask Agarsh that a simple question. That is, why in central conditions causing hypotonia, we don't get the, decreased fetal movements in utero. They are also having hypotonia, weakness, etc. Why we are not getting the central hypotonia conditions like cell weather and other conditions? We are not getting decreased fetal movements in utero. This is a very important differential pointing between LM and hypotonia, or the peripheral floppy and the central floppy. And one more question to Adira, that is, this why CP is difficult to diagnose less than 4 months. You think about it while the other person answers the other question. These 2 questions are slightly related, but not fully. The thing is, in the uterus, initially, the movements of the limbs are under the control of the spinal cord, and later on, brainstem takes over control. And after that, brainstem controls the movements very prominently till the 4th month postnatal life. Okay, but from the 4th month of postnatal life, cortex takes over control. And when that cortex takes over control only, then only the spinal cord understands and the lower motor neuron understands that something is wrong in the cortex. Previous to that, it did not know. That is why the manifestations of CP come out more profoundly, like the increased tone, reflexes, everything come out prominently. And we understand, we tend to diagnose CP after 4 months of it. Okay, now both questions are answered. You can continue.
Okay, sir. Natal history, full term vaginal delivery at local hospital Kanjirapalli, baby collection after birth, birth weight 3.1 kg, breastfed in an hour, urinary recording within 24 hours. Postnatal history, uneventful, no history of NNST, feeding difficulties or NICU admission, and baby was discharged on postnatal day 3 on exclusive breastfeeds. Development history, development milestones attained appropriately, no development delay. Now he studies in 5th standard with a good scholastic performance and peer interaction. He is active in sports, especially in football, and no regression of attained milestones or cognitive decline. Diet and nutritional history, exclusive breastfed till 6 months of age, complementary feeding started at 6 months of age with a raggy, family pot feeding started by 1 year of age. Now he is by 24-hour equal diet, he is taking 1900 kilocalories with an expected of 2190 kilocalories, 290 kilocalorie deficit, and protein intake is 30 grams per day with an expected of 39.9 grams per day, 1.9 gram excess. Is the child is on mixed diet. Diet includes good amount of cereals, pulses, egg, fish, milk, and meat. Diet lacks in consumption of green leaf vegetables and fruits. Child not under any nutritional supplements.
Okay, Aradi, one question. What
sir.
is the importance of dietary history? A very good dietary history. So, what is the importance of dietary and nutritional history in the in the case of a neurodegenerative condition, which could be kept as your case in exam? But
sir,
that
there is
yes.
Nutritional cause of peripheral neuropathies are there, like vitamin B1, B6, and B12 deficiency, as well as vitamin E deficiency, sir.
Okay, that is you are telling about beta lipoproteinemia and all those vitamin C and all. Okay,
Yes.
other than that, let us take the case of a Niemann-Pick disease. So, or a Tay-Sachs or other thing. And if there is an associated pediatric condition along with them, you will your examiner, pediatric examiner, will want you to take a very good nutritional history so that he wants to dissect between whether the poor nutrition caused this failure to thrive or the failure to thrive was caused by the primary condition. You understand? That is the Niemann-Pick disease, tyrosinemia, etc. have got failure to thrive as a very important symptom. So we want to know whether the failure to thrive is due to nutritional deficiency because the child is not taking, or is it due to the primary neurological condition? Okay, that differentiation, it will help. Okay. And one more thing regarding severe malnutrition, grade 4 PEM usually has got an association with a slight motor delay. That is only applicable in case of a mild motor delay can be produced by grade 4 malnutrition. Body always tries to conserve the nutrients and food to the brain. Okay.
Immunization history is immunized according to the national immunization schedule. 10-year vaccination pending. No recent immunization or no history of any adverse events following immunization. Family history, no history of specific illness in the family, no history of child loss, congenital anomalies or deformities, or wheelchair-bound personalities in the family, or muscular disease or abnormal facies or cataract or premature baldness in the family. Mother is 31-year-old, she is healthy. Father is 40-year-old, he is healthy. Sibling is 3-year-old.
One specific thing you will ask the mother specifically.
Myotonia.
What is it? That is one. Very good. Myotonia that you can look in the mother. Very good. That is, but myotonia usually the pattern of weakness is distal.
Yes, sir.
Pattern of weakness is distal. Unlike Venkat, can you tell me one condition, myotonia condition, which can present as proximal weakness? Venkat, myotonia containing condition which can Stanlopathies, and also especially there is a condition in Fenichel that you that is called a proximal myotonic myopathy. See, when we are pediatric PGs, what we did was we before the presenting day, we will take the corresponding chapter in the Fenichel. Nowadays the people are not using that much. That if they are mainly resorting to IAP pediatric neurology, there is a good book, I understand, but this Fenichel thing that gives you an idea. Symptom, it's a symptom and sign approach. So you take the differential diagnosis, you read regarding it, you present next day, and when whatever question examiner asks, you note it down, even to you and the other person. Then we understand our deficiencies. We go back and read that day itself. So that is the way. Not in this IAP club. This is very late. You go to sleep after this. But I'm telling regarding your final year presentation. And I even used to give some bribes, etc., to co-PGs to get the presentation from them. Because only when we present, we understand our deficiencies. Otherwise, we will think that we know, I know everything. So that is a problem. So when you present, that becomes, you become very powerful and you become strong in that case. And fortunately, that case, by God's grace itself, will come to you in the exam. In my DCH exam, the case that I examined in the ward and I cared much about, that case correctly came back when the loads were put. So that is the technique. You read a little regarding the differential diagnosis resulting from the presentation in the previous day, and presenting day, you take out the notes and the doubts and the deficiencies, you correct them that day itself. You become super strong. Why? Because there is an element of tension during case presentation. That element of tension actually kicks the nail into the memory. All the points are kicked into the memory very strongly. You will remember that case presentation always. Okay. Now you can continue. Now, what was the question I asked? A specific question to that mother. Anything like not myotonia. Myotonia, I understand. But the other question that I asked was proximal myotonic myopathy. There's a condition called proximal myotonic myopathy, PROM, PROMM. That condition, but unfortunately, that condition presents in adolescence or adulthood, not in our setting. I saw on real case in Sritra posting only, not in the childhood group. I have not seen that case. Okay. Then one more question that you need to ask the mother is whether the mother's brothers are involved or the male members are specifically involved. Why? That is, they are trying to find out any X-linked recessive transmission. Okay. Dystrophinopathies. We are looking for dystrophinopathies. Okay. Okay. Continue.
The sibling is 3-year-old girl child. She is developmentally normal and healthy. Socioeconomic history: mother is BSc graduate working at a care home abroad. Father is MCom graduate working as an accountant. According to modified Christmas scale, A belongs to upper middle class. The child living with his father and grandmother in their own house, 3-bedroom house with concrete flooring, plastered walls and tiled flooring. Then adequate ventilation and sanitation, no overcrowding, drinking water from sanitary well consumed after boiling, no use of plastic smoking or pets at home, not undergoing health benefits or scheme. Case summary from history: 10-year-old boy born as the first child of contemporaneous marriage with unlimited antenatal and cervical history, gradually progressive proximal muscle weakness of 1 year, predominantly of lower limb and truncal, without sensory bladder or motor involvement, without diurnal variation of symptoms, without significant family history.
Okay. Let us wait for 2 minutes before going to the examination. Let us wait for just 2 minutes. So we have got a this case of progressive proximal weakness of 1 year. Okay, and what are the from the history itself, Arathi, in neurology, in adult neurology especially, my professor Shaji Pravan sir used to say, when you are unable to make your diagnosis from the history, you are unlikely to make the diagnosis from the examination also. So what we did was we stopped at the history summary and we tried to formulate a diagnostic hypothesis. This is a step that is what we follow in other cases also. Respiratory system, cardiac system, everywhere we follow that rule. We stop a little or 1 to 2 minutes at the history, summary of the history, and we tend to think of the differential diagnosis possibility. So, like, can we take a central problem because there is no loss of consciousness, no seizures, no deterioration in etc. like that. Okay, and there is no history suggestive of any stiffness or anything. So we cannot take a hereditary spastic paraplegia, or we cannot take a spinal cord localization for this case because there is no bladder involvement. There is no history suggestive of any increased tone. There is no history suggestive of any increased tone or that is buckling and falling or any springy gauge. Another thing is springy gauge. Nothing is there. So we come down to the element. Okay, so now there is no history of any ataxia movement disorder. So we are ruling out other cerebral parts involvement. Now let us come down to the anterior horn cell. Can we have a differential diagnosis, localization of an anterior horn cell? Is there any condition which can present like this anterior horn cell condition?
Age and presentation, type 3 SMA could be a
okay. Type 3 SMA. That is called the Kujelberg-Villander, isn't it? Kujelberg-Villander. So type 3 SMA or juvenile SMA can present. And then another variety that can present is a rare condition. Autosomal, usually SMA is, autosomal recessive condition. But the autosomal dominant version, rare versions are there. They can also present with later presentation like this, like juvenile SMA. So let us now come down to the this thing that is Any other, the second possibility after the SMA, any nerve root, we are not very much interested, because nerve root problems in pediatrics usually present acutely, like GBS, etc. Only in adults we tend to talk about MADSAM, CADP, and other things. Now let us go to the second localization, that is nerve. Nerve conditions, do you think can present like this? Because it is comparatively less likely, isn't it? Nerve conditions usually, why less likely? Because this is a case of
Proximal weakness, not
very
distal
good, very good. Proximal weakness. It is a case of proximal weakness. How does the nerve present? When I teach, I tell distal weakness, wasting, and reflex loss. The characteristic of the nerve involvement is distal weakness, wasting, and reflex loss. You understand? What is the typical appearance in HMSN called as? The leg tapering.
fold drop and
No, that appearance of the thigh and leg, when you compare in HMSN, you say a particular appearance. To the Charcot-Marie tooth, that appearance. Inverted champagne bottle appearance, or stork leg deformity. Stork ഈ കൊച്ചി നമ്മുടെ ആലപ്പുഴ ചങ്ങനാശ്ശേരി റോഡിൽ കൂടെ പോകുമ്പോൾ കുറെ വലിയ കൊക്കു വരെ സാധനം നിൽക്കുമല്ലോ, അതിന്റെ കാലും തൈയും കൂടെ കമ്പയർ ചെയ്ത് നോക്കണം. കാല് ഭയങ്കര ടേപ്പേഡാണ്. That is called stork leg deformity. Okay, so that is less likely. See, the nerve localization is comparatively less likely. Next, let us come to the neuromuscular junction. Is there any possibility of a neuromuscular junction localization?
acquired myasthenia, autoimmune.
Yes, myasthenia we can say, but we have to tell the examiner that, sir, myasthenia starting like this will not last this much long without any other weakness coming, like the ocular weakness or the generalized weakness coming. Even though there is a variant of myasthenia called as limb girdle myasthenia, which also will later turn, it can evolve over months or weeks, but it can later evolve into ocular weakness. So that is not a very important thing. Then any other thing, like in adults, we can think of Lambert-Eaton myasthenia, etc. But that we are not going. It is a paraneoplastic condition that we are not going. Now let us come to the muscle. So finally, after saying that there is a possibility of juvenile SMA also, we come to the muscle, which is our most favorite destination. So muscle localization we can take. We cannot take the congenital conditions. Why? Because congenital conditions present congenitally or rarely. We have to take the acquired muscle problems. So in the acquired muscle problems, one great category is what? Dystrophy. You understand? Dystrophy. So in the dystrophies, there are three major groups. That is the dystrophinopathies, the sarcoglycanopathies, and the LGMD type. So can you tell some one or two characteristics of the dystrophinopathies? They can also present like this, isn't it? That is a differential diagnosis. As far as the Madam Arathi, that is the thing is, we are discussing only the history. When we take the history alone, do you think there is a possibility of dystrophy? History alone, without looking at the leg and all that. Yes, dystrophinopathies also we can consider, but we will refute it after the examination. Okay, dystrophinopathy we will consider, because dystrophinopathies also begin in the exactly same fashion. And let me ask you one thing: what is the muscle weakness that causes difficulty in climbing downstairs rather than upstairs?
Hip flexor.
Just to think and answer. I will give 30 seconds for it. You can close your eyes and think. I always, when somebody asks questions, close my eyes and think, because I am very much distracted by external stimuli. There is a sensory overload. You just this thing. What was the question, Arathi? I forgot.
Muscles helping for climbing stairs down.
Stairs. That is one person complains that I can climb upstairs, okay, but not much problem. But when I difficulty in climbing downstairs, I tend to buckle and fall and like that. What is the muscle that is involved? That is quadriceps. Quadriceps weakness. Quadriceps weakness can come in dystrophinopathies also. You say initially climbing upstairs will be difficult. Later climbing downstairs also may become difficult in dystrophinopathy, because quadriceps is one of the muscles involved in that. Okay. Then dystrophinopathy we can take. Let us take the second group. That is the sarcoglycanopathies. What do you tell? Actually, when I studied at my PG time, sarcoglycanopathies were we used to call under the category severe childhood autosomal recessive muscular dystrophy, we used to say anybody presenting with a Duchenne phenotype, if it is a female, it is most likely Kunju sir. Mohammed Kunju sir was my one of the great teachers for my teachers, and he's like an elder brother for me. Same position as my elder brother, Dr. Sulfikar. So the thing is, he used to taught me anytime you see a female child with that Duchenne-like phenotype, there are only two possibilities. What are they? One is it is a scar MD. We used to call it a scar MD. Severe childhood autosomal recessive muscular dystrophy. But that is the one that we are calling now as sarcoglycanopathies, and that also previously it was a distinct one, but now it has come to be grouped under LGMD. It is now considered as a subtype of LGMD. That I usually remember it as CDEF, CDEF, CDEF. So sarcoglycanopathies usually also can present like this, but they will have a Duchenne phenotype in the form of pseudohypertrophy. Let us see in our examination whether this pseudohypertrophy is there. Then we will categorize according to it. Then what about the third group, LGMD? Is it a possibility? It is also a possibility, isn't it? LGMD, because the thing is beginning with as proximal and girdle weakness, we are doubting. Okay. Any now, madam, we have localized one possible localization is muscle. After refuting the other localizations by saying that there is no diurnal variation, fatigability, ocular involvement, there is no upper motor neuron or other central involvement, no myelopathy issues, no spasticity, nothing is there. So we have actually localized it to only we are doubtful, slightly doubtful whether there is any distal weakness, because there has been a flat feet for what that install was where. So we don't know whether there is a proximal plus distal involvement or only a proximal involvement with a flat feet alone in the distal aspect. Then another possibility could be a ligament laxity, which may be associated with conditions like LGMD or the laxity conditions like Murphan and other things. But the LGMD can sometimes have ligament laxity associated with it, some subtypes, especially the sarcoglycanopathies or the fibrillin protein. Those can be associated with the ligament laxity. That we will come to it later. But madam, before we go into the further examination, any other differential diagnostic possibility other than this neurological localization, any other diagnostic possibility comes into your mind? In the anterior horn cell itself, whether there is any other diagnostic possibility? Rare only, rare. It usually presents with initially with weakness, but later on goes to develop other mental problem, dementia, etc. It's a neurodegenerative disorder.
Leukodystrophy.
Leukodystrophy, what is the problem? Spasticity. You yourself said that there is no frailness. You used to mean by frailness is flaccidity. There is no flaccidity or stiffness is there. Leukodystrophy, the typical presentation is initially with the spasticity and recurrent fault. But I appreciate your answer, because one of the common the differential diagnosis of this thing is of recurrent faults, especially in the lower age group, less than 4 years, is metachromatic leukodystrophy. Leukodystrophy. Even Krabbe, the late onset Krabbe can also present at 1.5 years. With the 1.5 years is the typical age of presentation of metachromatic leukodystrophy. But that is that can be begin with a normal development or a delayed development. But there is one anterior horn condition which I actually forgot during your presentation. I was actually anterior horn cell. I mentioned SMA only, but actually I forgot one more condition is there, which is rare only. It can affect the anterior horn cell along with the brain cells also later on. Initially, it may have anterior horn cell like presentation, but later we understand that there is dementia and neurodegeneration also. That is juvenile GM2 gangliosidosis. GM2 gangliosidosis, juvenile type, can initially present with anterior horn cell like presentation with the limb girdle weakness. Later on, it can lead to dementia and other things. So that is one possibility. Then any other differential diagnosis other than the dystrophies coming into your mind which can affect the muscle?
So myopathies, late onset myopathies.
Okay.
Like center core.
That is your meaning that the congenital myopathies which may have a later presentation. That also we can take. But usually when we go through the myopathies, we understand that the problems have been there from the childhood itself. When you analyze the history, that the child is not completely normal. And you know one thing, congenital myopathy is a disease with a plateau. It does not that much progress like congenital muscular dystrophy. Congenital muscular dystrophy, sorry, in between on Scotland call came, I rejected it. Congenital muscular dystrophy is actually a deteriorating condition. And you know what is the name, other name of the congenital muscular dystrophy? We quickly call it to understand the total of that. It is distinct from congenital myopathy. What is that name called? 3-word name. Dash, dash, dash disease. Congenital muscular dystrophy. Whenever I feel like, I don't have the answer, I suddenly tend to call Venkit, come here. My professor used to call Austin, bring the projector. Like that. Venkit, what is it? You are my only solace. I think Venkit has gone to sleep. No. Okay. Aarati, what was the question I asked?
The name is
It is called as eye-brain muscle disease. Eye-brain muscle disease. That is the easiest way to remember that. And mind you, it does not, in contrast to element disorders causing isolated motor delay, congenital muscular dystrophy causes global delay. Why? Because there is associated neuronal migration disorder in the brain. Yes, that is it. Associated retinal abnormalities are also due to, eye abnormalities are also due to migration protein deficiency. And okay, that we will, and also, you know, one thing, LGMD has got association with certain of these congenital muscular dystrophies. Because the same gene defect may produce both the congenital muscular dystrophy or LGMD like phenotype later on. So there is an association also. So let us, but congenital muscular dystrophy actually should be classified as a mixed floppy rather than a element peripheral floppy, because it has got a central feature. And one simple question to Gaurav: what is the difference between central and UMN?
The
And
central would have features like seizures or dysmorphism, which
okay. That is central. You see, UMN and central are not equivalent. UMN is just attributing to the pyramidal tract. You understand? Anywhere in the pyramidal system damage comes, UMN signs come. Okay, but this central means central nervous system. You understand? So when we call a central floppy, we are not meaning UMN. We are calling central nervous system involvement leading to floppy baby. You understand? That is that difference. Many of my PGs don't know. That is why I just wanted to say it as an offshoot. So whenever you somebody asks Gaurav or Ragesh or Akash, like tell me the classical human signs. You just say weakness in the pyramidal distribution, hypertonia, clasp knife type, clasp knife type hypertonia, hyperreflexia, or hyperreflexia and extensor plantar. Whenever somebody asks you what is the element signs, weakness in the element distribution, hypotonia, hyperreflexia, normal plantar, or normal or equivocal plantar, depending on the strength of the child. So this is how you should answer in the exam. When somebody asks you regarding what is human, what is element, what is central, what is the difference between human and central? Central just means central nervous system, not human. Those are not equivalent. Central can include human, but in our context, when we talk of floppy baby, etc., we tend to say central as a different entity. That is, a central floppy means central nervous system involvement, and we usually don't take the spinal cord in that. Okay, spinal cord conditions are completely different, compressive and non-compressive myelopathies and all that. So now that is a different type of case for discussion. So now let us think about other causes other than the muscular dystrophies which cause this problem. Can we think of something else? Like can we think of any muscle problems caused by inflammation?
inflammatory myopathies.
Okay, what are the two differential diagnoses in that?
The polymyositis and dermatomyositis.
Okay. Kunju sir taught me one important point that I will ask you. This patient that you are telling is presenting with presenting with a 2 months onset. Okay, not 1 year, 2 months onset of proximal limb girdle weakness, and you are suspecting both dystrophy as well as polymyositis. And you think that because polymyositis is an inflammatory condition, it should be associated with the fever and the tenderness of muscles, while dystrophy is not associated with the fever or tenderness. What is your opinion regarding my comment like this? I said just, what is Aarati? How do you refute me? No, sir, you are wrong. You say that you are wrong, sir, and you are telling the reason why I am wrong. Or Venkit can say, no, there is no Gurutam Koravannilla. Venkit can also say that what you are saying is wrong. When you are saying like that only, I will refer and find out that I was wrong. So you can say, nobody has complete knowledge. We are all having partial knowledge, like a net intelligence only. The net is never complete. So, Venkat, the thing is, Kunju sir taught me an important point. Don't be fooled by polymyositis. It can present exactly like a limb-girdle muscular dystrophy or Duchenne. And there won't be, in many cases, there won't be any pain or tenderness. And sir told me one thing also, that is in such a situation only, muscle biopsy becomes more important than genetic testing. I hope you understand the point. Then in that condition, that is why Kunju sir used to do muscle biopsy very regularly at that time, because he wanted to find out a treatable condition. Whenever we are considering a differential diagnosis, Chandra madam told me one thing, that is, you should always consider two things first: an ominous diagnosis first, and ominous meaning a life-taking illness first, because we had to suddenly act. Another thing that you have to think about is a treatable illness. So in this context, the treatable illness is what? Polymyositis. And polymyositis can very well present without any tenderness or fever or pain. That is also there. It will exactly mimic that. So that point being done, I'm not taking much time. What about dermatomyositis? What is the age group usually? Usually it can come. It can come, isn't it? It can come in this age group, but usually it is a little more younger, I think. This patient is 10-year-old.
10 years.
That usually I have seen cases at 4 years, 6 years, etc. And at between 2 to 4, and also I have seen one case, dermatomyositis. My experience is not that much of Kunju sir, because he has got 40 years or more, but I have only 10 years or something. So the thing is, any other muscle problem that you can think of, because we have come to the localization of muscle. Any other muscle disorder you can think of other than polymyositis, this inflammatory myopathy, endocrine myopathy?
Yes, sir.
Hypothyroidism, hyperthyroidism, like you said, hypopara and
Parathyroidism.
hyperparathyroidism.
Yes, sir.
Uh,
Cushing syndrome.
Okay. I still remember a young lady, 23 years. I went to a consultation, and everybody was saying and I also mistaken her for a dystrophy. Her shoulders are very much wasted looking, and I was thinking, what type of dystrophy is that? The shoulders are wasted, and finally, somehow I don't remember the correct way I proceeded. Somehow I found out the correct diagnosis. It was hyperparathyroidism. With the wasting of the bone, the chest wall and the bones had collapsed, leading to that frame. It was not the muscle that was problematic. The CPK was normal. So that is endocrine myopathies we should consider. But hyperparathyroidism can produce myopathy also. That is another thing. So then, what is the presentation of hypothyroid myopathy? What one presentation I already told you, like kosher Debre's hemline, but in an older age child, like for example, 12-year-old, the juvenile age group, 8 to 15, that age group, how can it present? Subclinical hypothyroidism can also present with the hypothyroid myopathy. In adult neurology, we tend to see cases occasionally, adolescent and young adults. That is, they usually present with a proximal muscle weakness without any calf hypertrophy or anything. So that type of hypothyroidism we should definitely rule out. The T3, T4, TSH, and the anti-TPO antibody, other things we can do. Then anything else in the muscle? Anything more in the muscle? Like, can I ask you one question? That is, Gaurav, can Pombe disease present like this? Pombe.
Yes, sir. Yes, sir. Late onset Pombe disease can present.
Late onset. Yes, late onset Pombe can present. But what will be the difference when Pombe presents late when compared to early?
Significant cardiomyopathy.
Okay. That is. Then what is the disorder that is exactly mimics? It's a muscle disorder, which muscle metabolic disorder, which exactly mimics Pombe. In both the presentation as well as in the cardiac involvement, etc. It is also a storage myopathy, like Pombe.
GM1, GM2, sir.
Can you tell?
Carnitine deficiency.
Yes, muscle carnitine deficiency. My son, actually, my third son is calling from the outside. One minute, 1 minute. But I'll mute the. Sorry for the interruption. He draws in my prescription pad. All my prescription pads are finished. And he is asking for another. That is not there here. Only one. Okay. Then, okay, I'll send him. No, what were we saying? Madam, muscle carnitine deficiency. Muscle carnitine deficiency exactly mimics and we had a really diagnosed during Kunjusar's time. We diagnosed with the muscle biopsy. That exactly presented with that pseudo hypertrophy of the calf and the muscular look and the cardiomyopathy. Everything was there. Okay. Then anything else we can consider? Juvenile POMB, muscle carnitine. Then we consider PM2 gangliosidosis also. But we can also consider mitochondrial. Very good. Mitochondrial myopathy. Very good. What is the full form? Gaurav, what is the full form of MELAS?
Myocardial encephalopathy with optic atrophy something.
No, MELAS. Mitochondrial. We tend to say encephalopathy. Mitochondrial encephalopathy, just like we say in ADM, but it is mitochondrial encephalomyopathy. It is not encephalopathy, mitochondrial encephalomyopathy with lactic acidosis and stroke. So it is encephalon is brain, muscle, myopathy is muscle. So it indicates a combined involvement of encephalon, brain and muscle. Mitochondrial encephalomyopathy with lactic acidosis and stroke syndrome. So in addition, there can be another condition similar to that with beginning with the M, which causes myoclonic epilepsy with the Ragd fiber. So that can also present. Then there are other mitochondrial myopathies also with the encephalopathy, which I have seen. We have a follow-up patient which has been diagnosed with some mitochondrial mutation. I don't remember correctly. I am very poor at remembering the genetic locus. So the thing is that patient has got both global delay as well as prominent muscle involvement also. So the thing, it's a very, very floppy child. So there can be like different types of mutations which can cause. Okay. Then we have considered most of the diagnostic possibilities. So now we have become a little wiser. I mean, we have tried to localize, and it is the muscle we are thinking. We considered various possibilities, and we are very curious to know whether it is there is a dystrophinopathy or a sarcoglycanopathy or this thing. What LGMD like phenotype. Okay, you can go to the examination. We'll quickly finish. I won't interrupt you in between. Okay.
Okay, sir. Physical examination, general examination, alert and cooperative, sitting comfortably on a chair, no pallor, express cyanosis, clubbing, edema or lymphadenopathy. Vitals, pulse rate 92 per minute, regular rhythm, normal volume and normal radial or radiohumeral delay. What other peripheral pulses palpable? Respiratory rate 22 per minute, regular abdominothoracic type, no paradoxical breathing. TP 108 over 68 millimeter mercury, measured in right upper limb in sitting position. SpO2 is 100% in room air, temperature is 98 degrees Fahrenheit. Head to foot examination.
Arathi, in the examination, when you said vitals, there is one system which deserves special attention in addition to the muscle. What is that system?
It's a heart.
Cardio. We are very curious regarding cardiomyopathy. Why? Yes, because many of the syndromes of LDMD have association with the cardiomyopathy, like teletonin deficiency and other further subtypes. But now there are around 34 subtypes. Very difficult to remember all of them. Only the major things we can remember. Okay.
Okay, sir. Head to foot examination. Head size and shape normal. Hair normal. No hair loss or baldness. No abdominal facies or dysmorphism. Eyes no cataract, ptosis or squint. Nose, ears and normal. Bilateral preauricular sinus present. Oral cavity normal. Mucus and dentition. Palate not high arch. Lips normal. Chest wall no deformity. Abdomen mild fatty protrusion of abdomen. Skin no rashes or goiter papules or hyperpigmentation. Distal joint hyperlaxity present. No specific muscle hypertrophy. No wasting of muscles. No contractures. External genitalia male type. Bilateral testis descended. No neurocutaneous markers. Bilateral pes planus present.
Okay, pes plan. Okay. That is the ligament laxity is there in the distal part only. Okay. Distal joint. Okay. Then. That can be seen in LGMD as well as in sarcoglycanopathies also. It is not pointing towards a specific type of condition or anything. Okay.
Okay, sir.
Okay.
Anthropometry, weight observed is 37.4 kg with an expert of 31 kg at the 75th centile. Height is 136.5 centimeter, expert of 137 centimeter between 25th and 50th centile. BMI is 20.1, is an overweight with an adult equivalent. Examination of CNS, higher mental functions. Child is well dressed, interested in surrounding and cooperative with examiner. Alert, conscious, attentive, oriented to time, place, and person. Memory both immediate and remote normal. Speech normal. Right-handed, no illusions or hallucination. Cranial examination.
Can I ask one question to Venkat in between? That is, Venkat, what is the difference between level of consciousness and the quality of consciousness? And what are the localization for each?
Level of consciousness is like the robotic consciousness is stupor, coma, normal.
No. What is the localization? Yes, you understand. As I understand, that is correct only. What is the localization? What tract or what system subserves the level of consciousness?
Ascending reticular.
Yes, ascending reticular activating system. Very good. Where does the quality of consciousness reside?
Cortex.
Cortex.
Which area specifically more?
Frontal cortex.
No, the cortical association areas. The association areas of the cortex, especially the polymodal association areas. They are concerned with the quality of consciousness. How the that is measured by what? The orientation in time, place, and person. Okay, orientation in time, place, and person. Okay, and where does the time sense reside? Where does the place reside? And where does the person reside? In which parts of the brain? Time is as it is in temporal lobe. Temporal lobe. Place in parietal lobe. PP parietal. And the person thing actually resides in the occipitotemporal stretch, which is called the fusiform gyrus. So that is where the face recognition and the person recognition is there. Let me ask one question, because this question sometimes your examination won't ask, but it's just asking only curiosity. You know, the fusiform gyrus is concerned with the face recognition. F is F. Understand? Fusiform is face. Fusiform gyrus is always called as occipitotemporal gyrus, inferior occipital temporal gyrus. So that occipital temporal gyrus is also on the right side is associated with the prosopagnosia. You know, that is face recognition defect. So if something happens to the left fusiform area, what defect occurs?
The inability to identify the non-faces.
Yes, that is visual object agnosia. So you have three cars lying in front of you: Skoda, Benz, and Maruti. You will not be able to say. You will be able to say these are cars, but you will not be able to say which car it is. You understand the final thing? Okay, you continue. And you know one thing. After consciousness, we tend to seek the orientation, and after orientation only, if the patient is oriented only, we will test the attention. And attention is usually tested by the digit span method, a digit method. And then after the attention is, if attention is okay, we will test the speech. And then after clearing out that the speech is okay only, we will test the memory. After clearing that the memory is okay only, we will test the intelligence. It is like that. That aspect you just remember, even though we know, but why we are proceeding in this manner is, if only the previous one is normal, we can test the next one. Okay. What is the problem in testing IQ in ADHD children? ADHD. Can you test the IQ in autism children? Is it, okay to test the IQ in autism children? And what is the problem with IQ in ADHD children? In autism children, autism is different from mental retardation. It is a pervasive development disorder. It is not only associated with IQ problem alone. This speech, everything is involved. So actually, we should not test the IQ for such children. Because once they communicate only, we know how much IQ they have. You understand? And regarding ADHD, you have to multiply the IQ obtained for an ADHD patient by the psychologist by 100 by 80 or 100 by 70 to get the real IQ. Because ADHD itself produces a apparent inattention and decreased performance. The performance speed tested by various intelligence tests is decreased because of the lack of attention. That contributes to a false IQ decrease. We had to multiply the obtained IQ by 100 by 80 to get the original IQ. Okay. What is the substance which increases IQ? In combination with the vitamin D and the zinc. Zinc and vitamin D are required for this substance to act in the brain, which can increase the IQ. That is DHA. DHA. Docoxahexaenoic acid. Docoxahexaenoic acid. It can also increase learning capability also in combination with the EPA. Okay.
The cranial nerve examination. First cranial nerve, child well appreciated smell of coffee powder, no anosmia or parosmia. Second cranial nerve, visual acuity, visual field and color vision normal, pupil size normal, shape normal, equally reacting to light bilaterally, direct and concentration pupil reflex present, accommodation reflex present, optic fundus normal. Third, fourth and sixth cranial nerves, no process, swing or nystagmus, eyeball movements pull in all direction. Cranial nerve 5, motor part, no temporal hollowing, masseter or temporalis palpated normally, no deviation of jaw while opening mouth or jaw drop. Sensory part, facial sensation over the 3 zones preserved, conjunctival reflex present, jaw jack absent. Cranial nerve 7, motor part, the normal eye blinking and wrinkling of forehead is present, eye opening against post eye closure is present, nasolabial fold is intact bilaterally, blowing of cheek and whistling present, platysma contraction present, no hyperacusis.
What is the difference between tongue protrusion and why we test the tongue pressing on the side of the cheek?
So the power of the tongue is assessed by tongue.
That is subtle weakness. Subtle weakness of the tongue is detected by the sideways test, while gross weakness is tested by the protrusion test.
Protrusion.
Okay. And one more thing that just in the vision. Okay. But regarding this olfactory, olfactory nerve testing, is it possible in newborns and the young infants?
No,
Olfactory
no,
testing.
As a breast milk, smell of breast milk.
Yes, correct. You're right. Very good. You're great. Very good. Even I actually came to know it only maybe around 6 years previously when I read Swayman only. I came to know. I noticed that fact. I did not give specific category because least tested nerve. So it is the aromatic. You see, you must tell in the exam the aromatic smell, the smell of organic substance. The aromatic smell is appreciated by the olfactory nerve of a newborn. Not all the smells, the aromatic smell. So you can open an aromatic oil like the clove oil or other eucalyptus or other organic oil smell. If you open a bottle, the child will have a behavioral arrest because of the sensing of the olfactory. That is called behavioral olfactory testing. By that technique, you can test the sense of smell in the newborn. Okay, you can continue.
Sensory part, taste sensation of the anterior tooth is preserved. Cranial nerves have 8. Cochlear part, Rennie, Weber, and airborne conduction test is normal. Vestibular part, no tinnitus, vertigo, nystagmus. Cranial nerve 9 and 10, no nasal regurgitation, no nasal twang in voice. Uvula central, movements of palate symmetrical, gag reflex present. Cranial nerve 11, side by side neck movements present, shrugging of shoulders present, no atrophy or wasting of trapezius or sternocleidomastoid. Cranial nerve 12, no wasting of articulation of tongue, deviation of tongue on protrusion normally. Tongue movements against resistance is present. Then examination of motor system.
And you looked at the tongue also, no fasciculations are there?
No fasciculations.
Okay. No. Can I ask one simple question? No, not a simple question. I remember when I said simple question, I remember a simple question asked by my professor Madhusudan sir in the final MBS examination. He told me, I will ask you a very simple question now. I was already afraid of losing, but he's asking, what is the fecal stercobilinogen level? Oh, that was the last nail in the book. I thought I'll fail definitely because who can answer such question? The thing is, simple question is, I mean, there is a in the anterior horn, not anterior horn cell, in neuropathies. When you consider floppy baby and also in the neuropathy, there are 2 types of neuropathy: HMSN and congenital hypomyelinating neuropathy. There is another neuropathy called congenital hypomyelinating neuropathy. What is the typical presentation of congenital hypomyelinating neuropathy? It is in the event of a floppy baby. Usually you encounter in the case of a floppy baby or an isolated motor delay or something. It's a rare condition, congenital hypomyelinating neuropathy. Venkit, if you are not asleep, can you contribute? congenital hypomyelinate neuropathy. ജന്മന തന്നെ എല്ലാ നെർവിലും hypomyelination. So what will it resemble? What disorder it will resemble, and how can we distinguish? It will exactly resemble a prototype disorder. It will not resemble HMS. It will exactly look like another disorder, element disorder. What is that? Anterior horn cells, SMA. It will exactly resemble SMA. So how do you differentiate it? Only one point
By
clinically to differentiate.
fasciculation, sir.
Very good, very good, very good. Fasciculations will be there in SMA, while other thing will not be showing tongue fasciculation. That is the only way. The other way is to test the nerve conduction studies. Okay. Recently, we had a case referred from KIMS, which I sent, which I actually, sir, the case was not seen by Kunju sir. It was around 2-3 years back, I think. And so somebody else saw, I made the diagnosis and I sent to Kunju sir back for doing the NCV, nerve conduction study. And sir also agreed with the diagnosis. Okay. Then you proceed.
The examination motor system bulk appears normal bilaterally, no proximal or distal wasting, no pseudo or true hypertrophy or contractures, tone, normal posture, no muscle soft on palpation, tone slightly reduced on passive movements on all limbs, no percussion or grip myotonia. Power, neck flexor grade 4-, neck extensor grade 4, abdominal muscles grade 4, umbilicus in central position, extensors of spine 4.
Okay, one minute. The previous slide, just one previous slide. Neck flexor grade 4-. Very good. Neck extensor grade 4. That is, flexors are a little more weak than extensors. Okay, okay. That we usually tend to see in polymyositis. There is gross neck flexor weakness, but more than this, maybe like grade 3 or grade 3- only in polymyositis we tend to see. But in dystrophies also it can come. Okay, neck extensor. Then abdominal, I didn't see. Okay, so you are testing now. Okay, okay, okay. He's training too much. Okay, okay.
Yes, sir. For the
But,
neck
okay.
extensor, sir.
Neck extensor also he after wow, okay, he suddenly fails. Okay, so he has got 3+ or maximum
3+ or 4-,
or
sir.
4-.
Yes, sir.
Okay, okay. So flexor and extensor both are involved. Okay.
So for the abdominal muscles.
Abdominal muscle. Okay. Okay. They're also weak. Now he's trying to rise from the using the upper limbs, which are comparatively spared. He's rising from that. Okay.
Yes, sir. And so the power of shoulder, that abductors are right and left 4, adductors right and left 5, no winging of scapula, flexion right and left 4+, extension right and left 4-.
Okay. Okay, okay. Can I ask one important point in between? This is not related to muscle, but this is a very good point. What are the anti-gravity muscles in the upper limb and the lower limb? Anti-gravity group of muscles in the upper limb and the lower limb.
For the upper limb,
I will give you two things. I will say flexors of the upper limb, flexors of the extensors of the upper limb, and the flexors of the lower limb and extensors of the lower limb. These are the 4 groups of muscles, out of which are the anti-gravity group of muscles in the upper limb, and which are the anti-gravity group of muscles in the lower limb?
Anti-gravity muscle in the upper limb is flexors.
Okay, very good. Flexors of the upper limb. And in the lower limb?
So also the hip flexors and knee.
No. Just think and tell. You said correctly. First answer was correct.
Extensors. Lower limb is extensors.
Flexors of the upper limb and extensors of the lower limb are the anti-gravity muscles of the body, which is typically denoted by the position of a hemiplegic person. Just to think, to remember a hemiplegic person. Here his legs are extended, but his upper limb is kept in a flexed hemiplegic posture. You know the hemiplegic posture. Okay, that just to remember that. So just to understand, Arathi, the opposite group of muscles are the pyramidal preference muscles, which are more weak when a pyramidal lesion is there. When somebody asks you which group of muscles are more weak in a pyramidal lesion, not in an element, pyramidal lesion, you say the extensors of the upper limb and the flexors of the lower limb. Why? Because if you want to take an object, you have to extend abduct, isn't it? That is a voluntary activity. So the extensors of the upper limb are the pyramidal preference muscles, while the flexors of the lower limb help you to walk. Walking is non-anti-gravity, standing is anti-gravity. You understand? So the non-anti-gravity muscles are preferentially supplied by the pyramidal tract. So when there is a pyramidal tract lesion, the pyramidal preference muscles are more weak and have got less tone. So the body tends to go into the hemiplegic posture. Okay, you can move.
So for the elbow, wrist, and hand, in both right and left, I got 5 full powers and for all the muscles, and with a good hand grip bilaterally.
Hand grip
Then
is
for
very good. Hand grip is strong.
good.
Okay.
Yes, sir. Strong, sir.
No.
For the hip flexors and extensor, right and left 4 minus. Abductors and adductors, right and left 4. And internal rotators and external rotators of thigh bilaterally 4.
Okay,
Knee
adductors are equally weak like the other group.
Yes, sir.
Okay.
But
Why I
flexors and extensors are more.
specifically looked at the adductors? Any diagnosis I am trying to
Sir,
get or something?
Sir,
Adductor.
adductors are more involved.
We are thinking of one possible diagnosis. We are thinking of say LGMD, isn't it?
Yes, sir. The adductor muscle
Adductors
is
are
more
preferentially in a very common type of LGMD, which accounts for 35 to 80% of the LGMDs totally. This adductors are more preferential, even though other muscles are involved. Adductors are preferentially involved. What is that type of LGMD? It is, that one protein. You can call by the protein name or by the. No, not sarcoglycan. It is sarcoglycan. You see, has got a dystrophinopathy type of picture. Usually, that is calpainopathy. Calpain deficiency. That is called the LGMD. If I remember correct, it is LGMD 2A. I don't remember much of the latest classification. The latest classification is LGMD recessive and dominant, and they have given the equivalent of the previous also. They have given in brackets the previous version also. So LGMD 2A is the one that we used to call as calpainopathy. 2A. And 2B is the dysferlinopathy. And the dysferlinopathy tends to cause 3 types of presentation. It can four types. Just note it down. Dysferlinopathy has got 4 types of presentation. One is it can present like LGMD. Second is it can present like an axial myopathy. The axial muscles alone get weak initially. Third, it can present like a Miyoshi-like myopathy. That is, gastrocnemius muscles are involved. And fourth, it can present with the anterior compartment myopathy. So these are 4 types of 4 types of presentation of dysferlinopathy. That is LGMD 2B. LGMD C2F. I told you C-def. When you remember when I read Fenichel, I usually remember C-def. That is sarcoglycanopathy. But I cannot remember like alpha, beta, gamma, like that. That is very difficult. But sarcoglycanopathy we can tell. That we previously used to call as SCARMD. Now, calpain, by looking at the adductors, I was trying to find out whether they are disproportionately weak, which may mean a calpain D3. Okay. Now you can continue.
So for the knee flexors, I got 5 bilaterally and extensor 4 plus. An angle, plantar flexor, dorsiflexor, angle inversion, and dorsiflexion, plantar flexion, I got full power.
Extensors are weak, isn't it? Extensors are weak. Okay. Actually, it is looking like an LGMD bar dystrophinopathy like that. Okay. But there is no pseudo hypertrophy, isn't it? Pseudo hypertrophy is not. No pseudo. So the dystrophinopathies are out actually. Okay. He's not climbing on that level. He has not reached. He still has some strength in the erector spina. You see, he's only partially weak. He's not climbing on the typical goer is not there, but the modified is there. Okay.
Reflexes, superficial reflexes, corneal not tested, congenital present, gag reflex present, abdominal reflex present, premasteric reflex present, and plantar bilateral flexor. Deep linear reflex, Georgia absent, biceps right and left 2 plus, triceps right and left 2 plus, supinator right and left 2 plus, knee jerk right and left 3 plus, ankle jerk right and left 2 plus, no primitive reflexes.
Okay, what is the difference between Ragesh or Gaurav, whoever is present in the conscious state, ascending reticular activity system, stimulated state? So the thing is, what do you, what is the difference between the brisk and the exaggerated when you are observing the reflex? Other than the 3 plus and the 4 plus, what is the difference between brisk reflex and exaggerated reflex? When compared to a normal reflex, what is brisk? As the
Normal,
name,
sir.
as the name
Subnormal.
says, it is brisk. The rate, the speed with which you get the reflux is very fast. That is called brisk. So if the rate and range of the reflux is increased, it is called exaggerated. You should answer like that. If the rate is increased, it is brisk. When compared to normal, it is brisk. And when the range is also increased, it should consider it as exaggerated. Okay. And suppose you are doubting. See, one case of a possible CP or pyramidal lesion you are examining, and you are getting a brisk reflux. It is between the brisk and the exaggerated that PGs have the maximum confusion, and you are doubtful whether it is we should say it as exaggerated or not. Suppose you get a clonus and a plantar upgoing, you will say, okay, it is exaggerated, even though it is brisk. Okay, but the thing is there any other reflux which will help you? I mean, say that it is exaggerated. Nearby reflux only, near the knee. One more reflux we'll get. That when we stimulate the knee jerk, we will get one reflux from the opposite leg.
Cross extension.
Yes, cross adductor reflux. If you get the cross adductor also, that means the UMN is there and the pyramidal lesion is there. So you can definitely say that the reflux are exaggerated. Okay. And another thing, Mohammed Kunju sir taught me that that if in infants or in small children, if you have a doubt, I mean, like you have a doubt whether it is exaggerated or brisk, you are not able to decide fully. You just tap the what tendon? What is that? The cruciate tendon. What is that tendon called? The knee jerk tendon. I forgot. Achilles is the angle jerk. Anyway, the quadriceps tendon. The quadriceps tendon. You just you give a tap with your index finger. If you give a tap and the reflux suddenly is obtained, then that means the reflux is exaggerated. But if you're just a simple tap, not a tap for the reflux, just a simple touching type of tap on the quadriceps tendon, and the child is reacting, that means the reflux are exaggerated. This is one point Kunju sir taught me. Okay.
Sensor system examination, light touch and pain sensations well appreciated bilaterally, temperature not tested, joint position and vibration sense normal bilaterally, cortical sensation, 2-point discrimination and stereotosis normal. Examination of cerebellar functions, no signs of incoordination, no pass pointing or rebound.
Adira, one person has got a loss of both the joint position and vibration in the in the leg. Another person has got a vibration sense loss only. Is there any difference in that? I mean, any point you get? In peripheral neuropathy, you can have loss of vibration sense, and later when you may get, because of the deafferentiation, you may have a joint position problem also. But if it is a posterior column problem, you may sometimes lose both. Okay, so this is actually applicable not in children, only in adults who can cooperate and who can say specifically. You know how difficult it is to test the sensations in children, and that much difficulty is there in adults also. They say everything opposite when you test again. And so Chandra Madam always says one dictum: motor signs are the hard signs. Remember, motor signs are the hard signs which help you make the diagnosis. Sensory signs are the soft signs which may help in corroborated diagnosis. And odd signs always should make you rethink your diagnosis. One time I quarreled with Kunju sir that one patient was there, one infant. He came with floppiness and developing over a period of 1 month. And when I examined, I said, sir, this is a case of SMA because there is arefluxia. And then sir came and just touched it. Is by sir's magic touch, the slightly reflux came. Then I told sir, it is vibration due to your knee hammer, sir. And this is SMA only. I was adamant. I said I got fasciculation in the tongue. I was a PG then, like you. I carried the only. And then we admitted the case. Sir became right finally. How? The child was detected to have hypokalemia. The further investigation showed it was a renal tubular acidosis. And Sir was right, the reflux were preserved, and I became wrong. Okay, we learned from our mistakes. Okay, then. Okay.
There's no truncal or gait ataxia, no generalized, there is generalized mild hypertony, no involuntary movements.
Okay.
Examination of autonomous nervous system, no abnormal sweating, postural hypotension, redness or sleep disturbance, There's no signs of meningeal irritation. Peripheral nerve examination is done. There's no thickening or tenderness of any peripheral nerve. Gait, normal stance. Gait is waddling gait.
Okay, paddling it. Okay, we can when we examine neurology, sometimes we may have to put, if it's a female child, we have to be very careful. May put screen and all that. But male child, we can have him wear knicker or we need to see the knees and the thighs, etc. So the ideal will be to remove the shirt, put a knicker or underwear or something, and give him some amount of privacy. Test him inside our room, PG room or something. That will be better rather than all the people looking on. She will be shy also. Okay. And
Examination of skull and spine, no tenderness of spine or spinal deformity, skull normal.
another
Other
thing in the
system-
examination, remember, one examiner tried to trick me. That is, I was standing on the left side of the patient. He's asked me to examine the sign from the left side. Fortunately, I remembered and came to the side. Actually, it is a trick, like the motor vehicle inspectors do. They asked us to stop in front of the side lane. And because we are afraid, we stop. And suddenly there is a break of the law. Like that, always, when the examiner says you come to the right side of the patient and examine. And one more dictum, remember, whenever you are taking a neuro case as part of your neuro posting or as part of your case presentation or as part of the last phase where you present in the immediate fashion, 45 degree or whatever it is, you go to the patient, take a stool and sit down by the patient, and then only take the history. Otherwise, when you are standing and taking history, you will become impatient and would want to finish it as early as possible. This is a dictum told to me by Chandra madam. Always take a stool or chair and sit beside the patient and take the history. Okay.
Okay, sir.
And we have become wiser. We have become a little wiser after the examination. See, we were thinking of dystrophinopathies and sarcoglycanopathies in addition to LDMD. But after seeing that there is no calf hypertrophy, isn't it?
Yes, sir.
No calf hypertrophy. Did you get any valley sign or anything?
No, sir, no.
The upper limb,
No.
like you had to examine by pushing on the wall and seeing
I
the
did,
posterior
sir.
axis
I did it,
fold.
sir.
That
Yes,
is
sir, I
not
did
there.
it.
That is
No,
not
no,
there. Okay.
no,
And
sir.
you don't have the pseudo hypertrophy also. So most likely there is no sarcoglycanopathy or no the other thing also. The dystrophinopathy is also out. Any new, but just before finishing, any new, I mean, what are the drugs? Just say the name only. What are the drugs we use for dystrophin, that Duchenne muscular dystrophy?
Sir, usually we use
That is
prednisolone or
prednisolone. Only
deflazacort.
prednisolone.
Yes, sir.
Only prednisolone.
Deflazacort.
Deflazacort. This has got low side. So one drug I like, deflazacort. It has got less side effects. Any other steroid, new steroid action drug? Steroidal anti-inflammatory drug that differs from the present glucocorticoids. That is vamorolone. It's a new drug called vamorolone. I don't know whether it has come to India. I have not used it. I have used it only after deflazacort. It is in use in US. And what are these the newer therapeutic drugs in, that is antisense oligonucleotides? What are the any name like?
So the drisaprocin and etiliprocin.
Yes, very good, that you just refer before the exam. It may be asked as part of theory question. Okay. Also, it can be asked as part of oral, but for theory, you just note it down these things like newer drugs in Duchenne muscular dystrophy. Note it may be asked as a short note or something, and because it is a pediatric topic, Duchenne muscular dystrophy. And another drug is there is a histone deacetylase inhibitor group of drug called givinostat. It is it's given for patients aged 6 years and older, with all genetic variants. It is given, and there is one gene therapy thing that actually recently, because of the case only, I referred and found. I did not know regarding that. That is called Elevidys. It's a long name. The gene therapy things are very long name. So they will make it as Elevidys, dystrophinopathy coming in the last part, DYS. Okay. Just so you continue. We'll finish.
Sir, this is the examination with a normal level, sir.
Normal. One more system of importance is respiratory system only. And because we want to find out whether there is any scoliosis causing restrictive
lung
pulmonary
disease.
disease. Okay.
Summary, 10-year-old boy born as a first child of
And
non-consanguineous marriage.
even though it does not give much details, you read a book by, there's a good book on in the Scott series. That is a book by doctor from Jibmar, I think. Manoharan or something. I forgot his name. That book is a good thing for reading. Quick reading and quickly understanding conditions, but no very much details are not there. But it's good for just before examination reading. It is good. IAP pediatric neurology book is also very good, but that gives more detail. IAP pediatric neurology book gives more detail in certain aspects like floppy baby approach and all that. So three books you keep in hand. That is Fenichal, IAP pediatric neurology book, and this book by that author's name I forgot. It is Ranjit Kumar Manogaran, I think. It is Ranjit Kumar Manogaran. That book is also very good. In addition to, okay.
Okay, so summary, 10-year-old boy born as a first child of non-consanguineous marriage with uneventful antenatal and perinatal history and without significant family history, with gradually progressive proximal muscle weakness for past 1 year, predominantly of lower limb and truncal, without sensory, bowel, bladder or cortical involvements, without diurnal variation of symptoms. On examination, found to have bilateral pes planus and preauricular sinus and distant joint hyperlaxity. Neurological examination showed generalized mild hypotonia, positive Gowers sign.
When you are summarizing, always remember one principle. In the previous slide, can you just take the previous slide? Because you already said a history summary previously, you can omit the without thing.
Okay, sir.
Without thing means sensory, bowel, bladder, etc. And you can take out all the negative things. This is one. This is what we examiners want. Like I have opted out of MD pediatrics examinership because my mother is very old and I cannot travel outside. So I can go only for the DM examination. But the thing is, this negative. I heard all the examiners saying this negative things are not to be said in the summary. Summary mainly positive points only. So you can quickly summarize in one paragraph all the history as well as the positive points. So this is just I am telling only, not for any that is criticism or nothing criticism. Okay, just telling. Okay.
Neurological examination showed generalized mild hypotonia, positive Gowers and along with the proximal muscle affecting shoulder of abduction, flexion and extension, as well as with the weakness of hip muscle, flexion, extension more than abduction, adduction or rotators, and axial muscles, neck and truncal muscles with the waddling gait, normal reflexes, sensory system and cerebellar functions, and other system with the normal limits.
Okay, that knee jerk we have got it as normal now.
Normal,
okay.
sir. Normal,
It may be normal in the initial some time.
Yes,
after when the cordyceps becomes more weak. So can I ask one simple question? When compared to neuropathy, usually have a distal reflux loss. But what is the pattern of reflux in myopathy cases?
So usually it is affecting proximal muscles.
That is one point. That is correct. You are correct. Proximal reflux are lost early in myopathy illnesses, and distal reflux are preserved till late. That's a dictum I was taught in pediatrics. When I was in pediatrics, I was taught like the proximal reflexes are affected in myopathy or muscular dystrophy. So especially muscular dystrophy, and the distal reflux are angle jerk is preserved till late. And the opposite is applicable to neuropathy. That is the distal reflex are lost initially, and the proximal reflex are preserved. Spared. Okay. So, but there is another point in congenital myopathy as well as other myopathies which affect both parts of the body, like the upper limb and lower limb. You can say one more thing: the reduction of reflexes. That you can say the reflex, deep tendon reflex are proportionately reduced. If you say that also, it is okay. Like you can say one more point is in congenital myopathy. Take an example of congenital myopathy. What do you say about the reflux? We say in congenital myopathy and congenital muscular dystrophy, there's a proportionate reduction of reflexes as per the strength of the muscles. As see, full strength, full reflex. Strength is half reflex. You understand? That is so. I will tell you on anterior horn cell areflexia. Distal, that is in the case of floppy or isolated motor delay, anterior horn cell areflexia. Then HMSN, distal reflex loss. In neuromuscular conditions like congenital myasthenia, retained reflexes. In myopathy and other muscle problems, proportionate reduction of reflexes. This is the pattern in 4 element localizations. Okay. Diagnosis: chronic proximal and axial muscle weakness, probably muscle myopathy or muscular. You can say, now you can say muscular dystrophy. There is no problem
Muscular.
about
Okay,
muscular
sir.
dystrophy as the first diagnosis. And if you are asked the differential diagnosis, you can tell the case of a juvenile, possibility of a second possibility of a
sir.
juvenile SMA, or GM2. You need not say. You can say juvenile SMA or mitochondrial myopathy. So those two things you can say. Then you can say, you can also consider endocrine and other myopathies like POMB, juvenile POMB, because they are rare. So the common things are common and uncommon things are uncommon. This was taught to me by Professor Dr. Joy Philip, who passed away a few years back. He only taught me this principle. Common things are common and uncommon things are uncommon. The rare presentation of a common illness is more common than the common presentation of a rare illness. These things you should remember when making a differential diagnosis. Okay, different diagnosis: limb-girdle muscular dystrophy. Emery-Dreifuss, you please take it out, because Emery-Dreifuss has got contractures, prominent contractures.
Okay, sir.
And
Okay, sir.
and the congenital myopathy also you take it out, because the patient is exactly normal. So we take it out the 2, 3. Becker you can
Okay,
keep.
sir.
Becker you can keep, but Becker you should have had this Becker also you can take it out. Why? Because no
There's
pseudohypertrophy.
that's it.
So the 2, 3, and 4 you take it out. The autoimmune myasthenia gravis, okay, you take it out and you replace it with the limb-girdle myasthenia. That you can say. But after limb-girdle, I think you can okay, that is okay. Limb-girdle and limb-girdle myasthenia. After limb-girdle, maybe you can put it as a juvenile SMA as the first differential diagnosis. Juvenile SMA, because nobody will object. See, you are doing clinically only. You are not investigating. So juvenile SMA you can put at the second diagnosis, and that is SMA type 3 or juvenile SMA. And the third you can put as juvenile myasthenia, limb-girdle myasthenia. That you should specify limb-girdle myasthenia, not as autoimmune myasthenia. Only say it as limb-girdle myasthenia, because then the examiner will be a little angry, because the ocular involvement he expects. So which condition among these, among the myopathy, SMA and the autoimmune myasthenia, etc., which condition typically spares the ocular muscle? Ocular sparing is a great characteristic of one group of conditions.
SMA.
Very good, very good, very good. Anterior horn cells tend to spare the ocular muscles. And you just see all the other things: congenital muscular dystrophy, myopathy, everywhere the myasthenia, everywhere the ocular muscles are involved. Then endocrine myopathy you can say as the fourth one, and the fifth one is mitochondrial myopathy. That is, I agree. Okay, metabolic also you can consider, like you can say juvenile phobia or muscle carnitine, etc. You can say, even though there will be like okay, channelopathies also you can say. There is a slow channel syndrome can also produce this myopathy like presentation. Okay, we will then it's already very late. Okay. Yeah, okay. Investigation CPK, is it elevated?
No, sir. Repeatedly it is normal.
Normal. So that is why we should think of the differential diagnosis. Like we should check for this the muscle biopsy we have to do, and we have to check the this thing that an SMA analysis, gene analysis also we had to do, because the CPK is normal. And also on the checkout for any paraneoplasm, that is, you just check the chest X-ray and ultrasound abdomen, etc., for any malignancy inside. But it is unlikely. Why? Because the long duration. The malignancy would have come out. Then we can investigate with a nerve conduction study also you do, which is unlikely to become positive unless there is a neuronal involvement. That is, the anterior horn cells are involved. You will get lack of F response and long duration large amplitude polyphasic potential. That's called LLAP. If there is a new juvenile SMA like picture, you will get a finding called long duration large amplitude polyphasic potentials, LLPP. And if there is a myopathic involvement, you will get a BSAP, brief small amplitude polyphasic potentials. So that is okay. STOT, SCPT is also not raised. No muscle enzymes are there. So, and you know one thing, limb-girdle muscular dystrophy can exactly be like congenital myopathy in the CPK pattern. You know, congenital myopathy, sometimes CPK will be completely normal. In congenital muscular dystrophy, it will come to around 2000 or 2000 to 2000, because there is a dystrophy. In myopathy, there is no dystrophy. There is no destruction of muscle. It's an architectural abnormal. Like that, LGMD subtypes having similarity to congenital myopathy or sharing proteins, they can have normal CPK. So being a normal CPK is not a point against LGMD, and it is not a point against mitochondrial also. So you can consider, so being the CPK being normal, you can consider the differential diagnosis also strongly. I think we may have to resort to a, after completing the non-invasive things, we may have to resort to a muscle biopsy also of the affected muscle. If the quadriceps is partially involved even, we can take the lateral aspect from the vastus lateralis. Okay.
Yes, sir.
Okay, then it is already, time is already very, and thyroid, everything you had checked. Okay.
Yes, sir.
Okay, and also you please check the ANA, ANA and anti-double stranded DNA and the ANA profile also.
Okay,
Please
sir.
check that. Please check that also. ANA, anti-DS DNA and the ANA profile and the ESR I think is okay. ESR is 25 only. That's a point against an inflammatory diseases, which may come out to be normal only. Okay, okay. Okay, thank you very much. Venkit, everybody, thank you. Mohandas sir,
Thank you, sir.
everybody, thank you. Okay. Thomas, can I leave?
Sir, it's okay, sir. Thank you, sir.
Okay, fine, okay. Doctor, thank you, sir. Thank you, Virendra sir. Thank you. Because a lot of names were seen. I don't know who is faculty and who is PG. That is why I did not dare to ask anybody. I just restricted on the Venkit and the other scapegoats only. So sorry for that, because I don't know the faculty, all the faculty there. Okay. Okay, by God's grace, one day I will come
Okay,
and visit.
sir.
Okay, okay. Thank you very much.
Okay, sir.
Okay,
Thank you, sir.
Thank you,
Thank you.
sir.
okay.